Greg is joining in 10 minutes.
Third talk is Dr. Nilesh Kamath. He has already joined, and Dr. Rahul Damne has also joined. Dr. Sangeet Gawale is, I think, still not joined. He's down the line 5th.
Okay.
And we have to check Dr. Daniel Moya.
Yes. Ashok, do you have his number?
I've conveyed to him, he'll join in some time.
Dr. Joydeep will be joining 30 minutes late. He had texted that he was in a surgery. So by the time we have that time.
Yeah.
Ashok, how much time we have?
So we can start now.
You tell me when.
So we can start right away now.
Okay. Good evening, everybody from India. Good morning, everybody from the United States and Canada. It's indeed a great pleasure for me to welcome all of you to the first virtual Pune trauma operative course. All of us know that for more than a year, we have been facing this COVID pandemic. It's really a big battle, and I don't think we can say that this battle is over. So I think we have to find ways around this pandemic, and the first virtual Pune trauma operative course is our way out to continue the academics, even though this particular pandemic is troubling us. I feel very, very privileged that this Pune trauma operative course is associated with the McMaster University, is associated with the Pune Orthopaedic Society, and also with the mini IOA Con, the Shiv Shankar, who is the president of the Indian Orthopaedic Association, for associating with this course, and also Dr. Meena, who is the organizing chairman and the past president of IOA, for having agreed to associate and partner with the first Pune Trauma Virtual Operative Course. It's indeed an honor for us. Also, I would like to acknowledge the participation and the association of McMaster University with this. It is the first time that we are doing this course along with the McMaster University, even though the people from McMaster University have been a faculty on this course in the past. But today, I'm so privileged that McMaster University is associated with this course officially. And I want to thank for that Dr. Mohit Bhandari as well as Dr. Brad Petrizer. We know Dr. Mohit Bhandari, he doesn't need any introduction, but all I can say that now he has more feathers to his cap. He's currently the professor and chair of the Department of Surgery at the McMaster University, and that entails a lot of time. That entails a lot of responsibility. That entails a lot of work to take the department ahead, and especially in this trying times of COVID. But Mohit, we appreciate your hard work which you're putting in to take this position and live up to that position. We also know Mohit is the editor-in-chief of Ortho Evidence, and I'm privileged to say that this course has also been powered by Ortho Evidence, and there's one good news I want to share on behalf of Dr. Mohit Bhandari, that we are going to give a 1-year free membership of Ortho Evidence to all the participants of Pune trauma course, and this will be sent to you through email. Dr. Mohit, thank you for this. We have totally 800 plus registrations for this course, and all these 800 registrants will be very happy. I also want to thank Brad Petrizer, who's the co-chair for this meeting, along with the chairman, Dr. Mohit Bhandari. And I want to share some good news on this occasion of the inauguration of the Pune Trauma course. Dr. Brad Petrizer has been unanimously nominated as the associate chair for the education department in Department of Surgery, McMaster University. A big round of applause and congratulations, Brad, for this prestigious position, and I'm sure you will only do good for this position, and we wish you all the best for the same. Last but not the least, I want to place on record our Alumni Association, who has been a part of this course all the years, and they have been organizing it every year. And special thanks to Dr. Rajiv Joshi, the president of Alumni Association, as well as Satyajit Naik, the secretary. My apologies, I said last but not the least, but the last but not the least is the Pune Orthopaedic Society. And I also want to thank Pune Orthopaedic Society for having partnered with this meeting. President Dr. Karne and Secretary Dr. Abhijit, who's joined us. Dr. Karne has apologized because he is in transit to Jaipur for the IOICON. But Abhijit, please do convey our thanks to the whole executive committee of Pune Orthopaedic Society, and thanks for being with us. So thank you, Abhijit. We appreciate your partnership and participation. So friends, I welcome you for the first virtual conference of the Pune Trauma Operative course in association with the McMaster University. And I welcome all the delegates. We have totally 800 plus delegates for this course. It's a record number. And I want to compliment the organizing team, Dr. Chetan Pradhan, Dr. Chetan Puram, Dr. Atul Patil, Dr. Warid, Dr. Shende, and last but not the least, Dr. Ashok Sham, for all their work to put together this program. I welcome all the national as well as the international faculty. And now I hand over to Dr. Mohit Bhandari, our chairman of the Pune Trauma Operative course, to give his opening remarks and declare this course open. Over to Dr. Mohit Bhandari from McMaster University, Canada.
Thank you so much, Parag, and thank you all to the course organizers. Let me begin with quickly, and I know we are going to be having a very busy day, so I won't keep my remarks very long, but this year has certainly, or this past year has certainly not been a normal one. But then again, remember this, it was being normal that led to where we are today. We've learned so much, and we've pivoted quickly to adapt. Here we are at a first and record-breaking course with hundreds of delegates. We will not disappoint you. The association that is sponsoring this, the Alumni Association of the Sanchetti Institute, the Sanchetti Hospital, our course organizers, you've heard all of the groups that are engaged. We are going to put on a wonderful virtual course for you. As you know, we have great partnerships with OrthoTV, and Ortho Evidence will give you lots and lots of evidence throughout this session. But without further ado, let me declare the first annual Pune Orthopedic Trauma course in virtual format open for discussion. I may just ask, if I may ask quickly, just Dr. Brad Petrizer to give a few words as the course chairman. And once again, we both of us are grateful to our long-standing association with this course, and grateful to the course organizers who we know have spent hours and hours and hours organizing what I hope, and I know you will all understand, is going to be a wonderful, wonderful, active and interactive course.
Thank you. Thank you very much, Dr. Mohit. Appreciate your kind words. And now I request the co-chair of this Pune Operative Trauma course, Dr. Brad Petrizer, to say a few words. And congratulations again for your new position.
Thank you very much. And thank you so much to the Sanchetti Institute, all of the people that are affiliated with this course, and our organizers, Dr. Atul, Dr. Chetan, and Dr. Chetan. It is just with sincere thanks that we look to collaborate together with this first virtual course. And I'm looking at the program. It is just going to be, I believe, fantastic. And it's going to lead to great discussions internationally on orthopedics. So just a sincere thank you to everyone involved for putting all of this together. And I just look forward to the next couple of days.
Thank you. Thank you very much, Dr. Prad. Before I hand over the further proceedings to Dr. Chetan Pradhan, I want to thank OrthoTV for helping us to relay this program, and also Ortho Evidence for helping us promote this program. So thanks, Dr. Ashok Sham and Dr. Mohit Bhandari. Over to Dr. Chetan Pradhan now to start the proceedings of the day.
Thank you, Parag. On behalf of the organizers, I once again welcome all the delegates. And as Dr. Parag has just told you, we have more than 800 delegates who have registered for this course, and that's a record of its kind, even though it's a virtual course. And I thank all the faculty. We have a stellar faculty for this course, and I can't thank all of them enough, because in spite of their busy schedules and some irregular timings, faculty from all across the world has agreed to contribute, and I'm sure this will go a long way in making this course successful. I welcome Dr. Della Roca, who has just joined in from the United States as a panelist on this course. He'll be speaking in a while. So let's begin with the first talk of the course. Today is the day for all upper limb trauma. And to start this, we have a superb opening batsman in the form of Dr. Harman Johal. I'll just share my screen. Yeah, so to start the proceedings, the first talk will be on clavicle fractures. Dr. Harman Johal, for those who do not know, is a clinical scholar from an orthopedic and trauma surgeon from the Hamilton General Hospital, Canada. He's associated with the McMaster University. He specializes in overall trauma and joint replacement surgery. He has been associated with the PUNE trauma course for a couple of years now. Last year, he came here and did some fantastic demonstration surgeries. Those of you who were there last year know him. And without spending any more time, I'll hand it over to you, Harman.
Great. Well, thank you, Chetan. And I just want to thank the organizers once again for the invitation to participate. And although it's not the same as it was last year, it's great to see all of these familiar faces and connect with you all again. So thank you very much for the invitation and opportunity to speak with you guys this morning. I'm just going to, or this evening there in India, I'm just going to share my screen here and get things going. And just want to make sure everything is coming through there. Great, so it looks like things are coming through. Just want to review that we're going to be talking about clavicle fractures today, and I'll be reviewing an approach to clavicle fractures as well as concepts in terms of decision making. We're going to review the problem of clavicle fractures, the evidence associated with their treatment, how to go about making a decision in terms of the operation you're going to choose, or operative versus non-operative treatment. And then when it comes down to what surgical procedure you might be choosing, we'll review some evidence around the different options that exist. And it's just like many other things in orthopedics, the pendulum continues to swing back and forth with clavicles, and that contributes to the complexity of the problem and the challenges with coming up with a decision. And the operative choices specifically have proliferated over the last 20 years. And it's going to be important to think of ways to tease out which solution would be the best one for the patient sitting in front of you, as well as with the resources you have available to you. So what does the clavicle do? The clavicle acts as the functional strut for the upper extremity, And it also acts as a protector of the neurovascular bundle as it extends to the rest of the upper extremity and passes underneath the clavicle. So it certainly serves an important function in terms of the functional ability of the upper extremity, as well as protection of the neurovascular structures that pass through. It's not an idle bone, and although people think it might be sitting as a static strut, it actually has quite a bit of mobility. It works in protraction, retraction, elevation, and depression, as well as rotation. And when you specifically elevate your arm, it's going to also elevate 11 to 15 degrees, as well as retract 15 to 30 degrees and rotate almost 30 degrees. So it certainly is not idle as your arm is moving around, and it simply does not just strut out the arm. Now, it doesn't make up many fractures, and this is from the Swedish National Registry that shows it only makes up about 4% of the fractures. So what's the big deal? Why do we hear about clavicles so much? Well, it tends to happen in a high demand population, mostly young males. A lot of them are associated with falls from ground level or falls during recreational activities, sports, riding bikes. Motorcycles tend to be the most common source of clavicle fractures. And it tends to be in a population that is high demand and wanting to get back into functional shape. Now, over half of the fractures that we talk about when we talk about clavicle fractures are mid-shaft fractures, with a lesser portion being distal fractures, and the least prevalent will be medial clavicle fractures. Now, the reason for that is just the shape of the clavicle, especially in the mid portion of it. It's round and narrow, and it's the thinnest part of the clavicle and also the most susceptible to trauma. So when you have a trauma or a laterally directed force, the strong ligaments at both the AC and CC joints, as well as the sternoclavicular joints, tend to stay intact, but the clavicle wants to fracture and fail right in the middle with a laterally directed force or with a superiorly directed force. And over nearly half of clavicle fractures in the Swedish National Registry of over 2,000 patients were displaced. And part of the reason for that displacement is the associated muscular forces that pull on the clavicle once you have a fracture. So this includes the pec muscles, as well as the deltoid, and as well as the sternoclavicular muscles and the trapezius. Now, distal fractures make up a lesser portion of these, and we'll talk about some treatment options as part of this, but I think mostly as part of AC joints we'll talk about as well, with some pertinent treatment options relevant to distal clavicles as well. It's classified through the NEAR classification, and it really discerns the stability versus it discerns the stability of the fracture and separates stable versus unstable fractures, with type 2 A and B being more prone to displacement and functional deficits, as well as the type 4s and type 5s. So what's the problem? Now, really, with these fractures, the historic mainstay of treatment all the way from the 60s, with real legends of shoulder surgery, Dr. Neer and Dr. Rowe, emphasized that non-operative management was just fine. That it had a low risk of non-union, and it was described as being less than 1%, and it had a negligible functional impact, even with malunions. Now, multiple non-operative treatments have evolved, including slings, cuff and collars, as well as figure of 8 braces. Research has been done that shows all of these are relatively equivalent, and one doesn't really stand superior to the other. And in fact, maybe a figure of 8 brace might be detrimental in that it puts pressure directly over the clavicle, and although the thought is that it might help reduce the fracture, it may actually make things worse functionally if it causes pain. Now, what's happened lately? And really, since the 2000s, we've had a huge increase in the interest surrounding these fractures and possible operative management. And really, it started with Dr. Noack and Dr. McKee in 2005 and 2006, drawing attention to the fact that non-operative management may not be as good as we think it is. And there still are persistent symptoms in non-operative patients. Specifically, both found that displacement was a risk factor, and patients were continuing to complain of pain, reduction in strength, pain during activity, as well as cosmesis, issues with cosmesis with non-operative management of these fractures. So what that led to is really the paradigm shift in how we think about these injuries, with a randomized controlled trial from the Canadian Orthopaedic Trauma Society that hit the scene in 2007. And this looked at non-operative management versus operative management of displaced midshaft clavicle fractures. Now, certainly by today's standards, it wasn't a large study, but back then it was really groundbreaking, and it was level 1 evidence. Even though it only had 130 patients, it was really able to give us some guidance in terms of this question. And what it showed is, compared to non-operative management, operative management resulted in better functional scores, which meant improved constant scores, as well as decreased disability scores. and that at 1 year, the open reduction internal fixation group had better outcome scores, decreased time to union, as well as decreased malunion and decreased and lower rates of non-union as well. So what was really the impact of the study? And there was additional studies that looked into change in practice patterns that came around after this. And this is a study that looked at a retrospective review of databases from 2 level 1 trauma centers. And they compared and they looked at over nearly 700 patients who were treated both before and after the landmark randomized controlled trial from COTS hit the scene. And it showed that after that level 1 evidence came about, there was a 10-fold increase in those patients who were treated operatively with clavicle fractures. So certainly, again, even though it wasn't a large study, it was definitely an impactful study, and certainly one that continues to have an impact in how these fractures are thought of. Now, since that study came about, multiple other randomized controlled studies looking at the same question started to percolate through. And with that came studies of those studies. So systematic reviews and meta-analyses attempted to quantify the evidence and try to give us some direction. But really, I think these actually confused the landscape even more. Now, this is a study that was done in 2012, and it was by the McKee and the COTS group, or members from the COTS group. And initially in 2012, there was only about 6 randomized controlled trials with about 400 patients that showed that overall operative management significantly lowered the rate of non-union and symptomatic malunion, led to earlier function, but there was little evidence that long-term functional outcome with open reduction internal fixation was significantly superior. Following that, there was another review that came out of the McMaster group here, and that looked at 9 randomized controlled trials, again, just under 700 patients. But they really found that there was no difference in complications between the groups. And although there was a small functional difference, it wasn't what we would call clinically important. So it didn't cross a threshold for what we would say is the minimal change or significant difference you'd expect to see in someone who's actually noticing that there's improved function, which really kind of tried to switch the pendulum back away from operative management. And the most recent of these meta-analyses, at least until the one we repeated, looked at 14 randomized controlled trials and about 1,500 patients. And this was really supportive of operative management, given the randomized controlled trials that continued to come through, and it showed that open reduction internal fixation had, again, a lower non-union rate, shortened the time to union, had a slightly increased risk of complications. This included wound issues, as well as the chance of reoperation and removal of hardware. But then open reduction internal fixation was really associated with an improvement in both short and long-term functional outcomes. But this really didn't give us any direction, because as you see these kind of go one direction then the other, and when you have this type of signal, there's lots of noise. It's really hard to actually figure out what the right management should be. So we decided to take a more critical look, and we did what's called the network meta-analysis, looking at 22 randomized controlled trials, and this was just published last year. And this was really meant to quantify what is the best evidence for the management of these types of injuries in terms of both operative and non-operative. And really the benefit of a network meta-analysis is it allows us to compare multiple different interventions, including the different operative interventions, to help us determine if one of those options is really better than the other. So we looked at all of the different options in terms of operative and non-operative management. We had a non-operative arm. We had a subset of studies that looked at just plating options and the various plating options that exist, including anterior plating, superior plating, anterior superior plating, anterior inferior plating, as well as intramedullary devices that were both locked and non-locked. We had, as mentioned, 22 randomized controlled trials and over 2,000 patients, and we were able to do multiple comparisons between these groups. By far the largest group was the non-operative group that had over 500 patients, and then superior plating was the next most common, but there wasn't an insignificant number of patients who had an anterior superior plate, as well as an anterior plate or an IM nail. So this gave us an ability to really look at the question, and we looked at it at 2 levels. So the first level we wanted to assess it is just operative versus non-operative. What's the evidence? What's the best option here? And when we looked at all of the studies that looked at that comparison, it really showed us that open reduction internal fixation was confidently able to be associated with a decreased risk of non-union and had an increased union at 1 year of follow-up. When we looked at it all together, though, surgical management did not increase functional scores by amounts that we would consider clinically important. So the 1 year scores might be the same, although the patients did have a increased chance of union with surgical management, and they were getting union at a sooner time. But by 1 year, those differences were no longer important. So what does this tell us about management, and how are we going to proceed? Now, we have to think about what we've learned from these trials and what they've taught us about the indications for operative versus non-operative management. Classically, we would think of open fractures with neurovascular injuries, or fractures with polytrauma injuries that may benefit from surgical management. And as we started to see evidence evolve, we looked at additional risk factors, including whether the fracture was displaced, including lack of cortical apposition or shortening greater than 20 millimeters. If there was comminution, patients who are female, patients who are older, and patients who are smokers were all shown to have additional risk factors for non-union and may potentially benefit from operative management over non-operative management. But what is displacement? How do we really quantify displacement, and how are we going to be confident that that displacement exists? Now, there's a couple of things to keep in mind. Oftentimes, when these patients first come into the hospital, they're in the stretcher, they're in the emergent stretchers going to get x-rays. They might be supine, and that really might not be the best indication of whether or not this fracture is displaced. So we looked at 80 patients and compared both supine and upright x-rays in these patients who had clavicle fractures. And we showed that if you actually looked at the upright x-ray, you were 3 times more likely to determine that that patient might need operative management versus non-operative management. So really the position is going to be key in determining whether or not that patient might have a displaced versus undisplaced fracture. Additional considerations are trying to determine the plane of displacement and really what the impact of displacement is going to be. And so this is a nice study that looked at the 3D analysis of the displacement in both the AP planes as well as the medial lateral planes, and additional the front to back plane, and superior inferior planes as well. So we looked at it in multiple directions to measure the impact of displacement, and they had 67 patients whom they analyzed. And they showed that only the A to P distance, so the displacement in the front to back plane, showed a negative correlation with scapular angle. And that really led to scapular rotation of anterior tilting, internal rotation, as well as upward rotation of the scapula. And that's Dr. McKee, actually, if you've heard him talk about these clavicle fractures, that's really what he equates to scapular ptosis, or rotation of the scapula that leads to the shoulder dysfunction. And it was, it's interesting to note that it's not necessarily in the medial lateral plane or anterior or superior inferior plane, which we might classically think when you look at x-rays and displacement, but it's the front to back plane or the AP plane that really leads to any dysfunction in the scapula. So that's important to consider, and really makes you wonder, question, are we thinking of displacement in the right way? And that probably is part of the reason why we've seen so many mixed results in the studies that have come through. Another important factor in decision is timing, and I think this is probably the evidence that gives me the most confidence in my approach to clavicle fractures. And it was again from McKee and part of the COTS group that looked at the impact of delay, and they looked at patients who were treated acutely within 2 to 4 weeks of having the fracture, as well as compared to a delayed group. And it showed that whether the patient was treated acutely or in a delayed fashion, it didn't impact their 1 and 2 year outcome scores following management. And really, there's no difference in functional outcomes for those patients who have delayed open reduction terminal fixation. So why I really like this piece of evidence is that it gives me time, and it gives the patient some time to think of really the approach they want to take and the impact that this injury is having on their life. And then if we do decide to go for operative management, even on a delayed basis, it still gives me confidence in letting that patient know that their outcome is not going to be compromised by that delay. Now, if we're trying to pick out the patients who are going to do well early, one of the indicators that's come about in the last year after relooking at this data is patients who might have a minimal improvement of their pain in 2 to 4 weeks after their injury might have a higher chance of going on to non-unions. And this comes from evidence that's followed a group of patients out over the course of their clavicle management. And it showed that patients who had persistent pain beyond 2 to 4 weeks tended to have a higher risk of non-union. And that's the red bar that you see there. And the blue bar is those patients who went on to uneventful union, whom you really see having an improvement in their pain trajectory beyond 2 weeks, much better than those who went on to non-union. So potentially patients who are having problems early might be an indication that they may do better with surgical management. And really what this whole algorithm boils down to is it needs to be a shared decision-making process. So this is a nice piece of evidence that actually utilized some of the data from our network meta-analysis to create a decision board for patients. And it showed that patients, although there was a good mix of operative and non-operative management chosen by the patients, they placed a high value in the fact that their opinion was asked for, and their functional and timing priorities were taken into consideration. And that's really what made a difference for these patients. So this comes down to the evidence-based algorithm of trying to take patient preferences into consideration, as well as the research evidence that's out there, and really your own clinical setting, what you have available to you. Timing, especially now with COVID, there's been lots of attention to timing of fracture management, and this isn't necessarily one of those fractures that you, unless it's open or there's neurovascular compromise, that you have to take to the operating room in an urgent setting. You have time to make a decision. You have time to organize resources for that patient, and you have time for the patient to think about what's really important to them, and how valuable it is for them to have their fracture fixed. So say they are going to go on for operative management, what are you going to choose? Now, as mentioned, the market's proliferated in the last few years, and different plates come out the clavicle from different angles: anterior, superior, anterior, inferior, a mix of anterior and superior that kind of twist around the clavicle. And there's multiple IM devices as well, both locked and non-locked. And this is another aspect. This was another aspect of management that we looked at through our network meta-analysis that I'll get to shortly. Just a couple words on a couple of their options in terms of positioning. Now, this tends to be my preference, is to position these patients supine. And what I find is that kind of helps take a lot of the weight out of the displacing forces of the shoulder. And I usually have that patient on a radiolucent bed that allows me to bring X-ray and bring an X-ray and get the right angles to get perpendicular views. And I find that this, I prefer this over a beach chair, because I find X-rays are a little bit easier to get in this position. And again, there's fewer deforming forces. Incision wise, there's also questions whether to use a longitudinal incision or one that's in line with Langer's line, or like a saber incision that's more perpendicular, say, to the plane of the bone. There's been some evidence that shows that that's compared these two incisions, and has shown that although transverse incisions tend to have some issues with cosmesis, there's really less bleeding, and then potentially less chance of injury to iatrogenic injury to supraclavicular nerves with a more oblique incision that's in line with Langer's lines. But overall, with respect to function, there's no real difference. Now, in terms of what's the best option, again, using our network meta-analysis, and we compared all of the different options, we found that when it comes to union, the chance of the best intervention that came to the top was anterior plating. Similarly, when it came to risk of reoperation, anterior plating beat out superior plating as needing to have a revision to be removed. Functionally, anterior superior plating had a slight edge out on the other interventions, but really none of these differences were to the point where they were substantially clinically significant. It was just based on multiple comparisons, and overall, it showed that anterior plating might be better. And so, that's my quick summary of clavicle fractures in 10 minutes, or maybe a little bit more. And again, I just want to thank you for the invitation. And I really have fond memories of the last time we were in Pune, because that was really one of the last times I got a chance to travel. And I thank you again for inviting me to the course this time.
Thank you, Harman. That was a great talk. I invite Dr. De La Roca from Missouri to start his talk on periauricular fracture dislocations of the elbow. He's a little bit in a hurry because his patient is intubated and ready in the OR. So, Greg, maybe you can just take over.
No problem. And Chetan, thank you so much. It's a real pleasure to be here. I as well was in Pune about a year ago, and a little bit more. And I'm so sorry that I can't be there with you. So, but it's a real pleasure to be here. I'm going to speak about periarticular fracture dislocations of the elbow. My disclosures are not relevant to this particular talk. So as far as elbow fracture dislocations are concerned, the objectives of this talk are to understand the different types of fracture dislocations, to identify subtle signs of complex elbow injuries, to create surgical tactics and learn how to do this based on the injury type. And first and foremost, I know it sounds strange to say because this would seem to be obvious, but don't do anything that increases instability. And I'll get to why that's an issue in a moment. So we'll do this in a case-based format. This is case number 1. This is a 40-year-old male who was making a homemade set of fireworks. When one of them detonated in front of him and knocked him over, he landed awkwardly on his left elbow. And he sustained an injury. He was unable to move the elbow afterwards, presented to our emergency department. And if we look, you can see here that he has a comminuted fracture of his radial head. You can also see that he's dislocated his elbow posteriorly. So there's an empty greater sigmoid notch that's indicated here. And if you look in front of the distal humerus, you'll see that there is a displaced coronoid fracture as well. So this is a very classic injury pattern. This is called a terrible triad. They're called terrible because they've historically had poor outcomes. But I do believe that with a rational method of treating these injuries, we can improve outcomes substantially. And I believe that we have in general, as long as certain treatments are adhered to. And I'll get to that in a moment. The triad, of course, is the posterior elbow dislocation. It's usually posterior, with a radial head fracture and a coronoid fracture. And the basic principles are these. So first, it's important to consider repairing the coronoid, which really is a surrogate for anterior capsular detachment from the ulna. So what you're really doing while repairing the coronoid fracture is you're restoring the anterior capsule attachment and the anterior check rein of the elbow. The radial head needs to be replaced or repaired. You don't take it out, and that's one of the things that people used to do that would increase instability. Take an unstable elbow and make it more unstable by removing the radial head. Not a good idea. And then generally, since this is being done mostly through a lateral approach, the lateral collateral ligament is clearly visible in the incision in the surgical field. And so repairing the lateral collateral ligament is usually appropriate. In general, we tend not to create more instability. So like I said, don't resect the radial head unless you're going to replace it. But also don't ignore these small coronoid fractures. They really do have an important role in the instability. So fixing them is important. Restoring the capsule is important. They may not need to be restored anatomically, but you need that check. And sometimes if you need to fix it and you're staring at a radial head with minimal fracture, then you may need to go medially in order to get to the coronoid. Happily, though, the medial collateral ligament doesn't usually need operative repair, and at least that has been the experience that I've had, and people who have published on this, like David Ring and others, have also mentioned the same. So the general tactic, I keep these patients supine. I will do a Coker approach to the elbow between the extensor carpi ulnaris and the anconeus. We'll often find that the lateral collateral ligament is avulsed directly off of the lateral epicondyle. So you'll be staring at a bare surface of bone at the lateral distal humerus. So if you're going to resect the radial head, if you know this from your preoperative plan, then this is the time to do it. You take the radial head out. This improves your ability to access the coronoid through the lateral side. At that point, you can repair your coronoid / anterior capsule. And you can do this in a number of ways. You can do suture tunnels through the proximal ulna. This is what I normally will do because these coronoid fractures are small, and really what I'm trying to get is the capsule. You can also use screws or consider a medial approach. Screws and plating are difficult to do from the lateral side. So considering doing an accessory medial approach is really worthwhile. Then when you're done with that, you will complete your repair of the radial head, or if you've taken the radial head out, you want to replace it, and then repair the lateral collateral ligament during closure. And one thing I would encourage you is that don't tie down any of your sutures that you use to repair the capsule or the ligament until you have everything pretty much finished, because it's really a mood breaker to repair one thing like the capsule and then be manipulating the elbow and get everything done and think everything's great. And then you realize that your capsular repair has failed. So wait to tie everything down until you're ready to go, everything's done, and all you have to do is tie your sutures. So this is our 40-year-old iron worker who blew up a small firework next to himself. And this is him at 1 year. So you can see a small amount of heterotopic ossification that formed at his medial collateral ligament origin and also in the anterior capsule. But he has a stable elbow. We did replace his radial head because it was highly comminuted and complete. and he had excellent motion at the end. And I actually saw him in Washington, D.C. At our Capitol. This was long before our Capitol was stormed by the rioters in January, and he did well. So if we move on to the second case, this is a different type of injury. So this is a 22-year-old patient who was involved in a car crash where his arm was hit by the airbag as it deployed. And he sustained an immediate elbow injury, had lots of pain, was not able to use his arm at all. He couldn't move his elbow, and it was a closed injury. But if we look at the particular injury here, what you'll see is that the radius and the bulk of the ulna have traveled together. You can see that the relationship of the radius and the ulna, at least at the lesser sigmoid notch, seems to be relatively well preserved. You see that here on the lateral image as well. So what we've got is the elbow has dislocated anteriorly, but it's gone through the olecranon. All right, and so this is what some people will term a transolecranon fracture dislocation. This is also called by David Ring an anterior olecranon fracture dislocation. The nomenclature, just so long as you understand what you're talking about, probably is irrelevant. But basically what you need to recognize is that this is not a simple olecranon fracture. And so there is some literature, it's relatively old, small series, but treating these with tension band wire constructs really probably don't work very well. And the reason is that you're trying to control the entire forearm with the tension band wire. If we look back at this image, the lateral image on the right, yes, there's a big olecranon fracture fragment, but the unstable part in this injury is not the olecranon fragment, it's stayed put. It's the entire forearm. And so controlling the entire forearm with a couple of wires just doesn't seem to make a lot of sense. And it seems to be associated with inferior outcomes. What's really nice about these is so often the ligaments can be intact because the forearm actually rotates around the center of rotation of the distal humerus. So how do we fix these? Well, we would fix these with an approach similar to how we might fix an olecranon fracture. You do an extensile posterior exposure. I position my patients laterally. Then you can raise flaps. If there are radial head fractures, which sometimes will occur, you can get over to the Coker interval to do a radial head repair or replacement. You can address coronoid fractures if they exist through the fracture. And basically the biggest and most important thing is to reduce the olecranon anatomically. So you get the forearm back to where it belongs, and then usually use a plate and screw construct so that you have something fairly substantial holding the forearm reduced to the olecranon. And then again, the ligaments are often spared, so you may not have to fix the ligaments. So here's our 22-year-old again. And all we ended up needing to do for him was an isolated posterior approach. He had no radial head fracture. We reduced his proximal ulna and fixed it with a plate and screw construct, just like you see here. This is not a locking plate. And we didn't have to repair any ligaments, and he did great. And this guy ended up with near perfect range of motion, and he wanted his plate out because patients don't like plates on the olecranon after he healed. So if we move to the third type, this is a little bit of a different injury. This is a 65-year-old woman who was hanging some decorations for the holidays in her classroom. She's a teacher, and she fell off of the chair that she was standing on, landing on her right arm. So if we look at this patient also does have an olecranon fracture, but the pattern is different. So first of all, you can see that there's an apex dorsal angulation of the proximal ulna. You also see that the radial head is now dislocated out the back. And very often these can happen, there are radial head fractures that are associated. But then you also see that there's a large coronoid piece. And this is a fairly classic type of periarticular fracture dislocation. And some people call these Monteja variants or posterior olecranon fracture dislocations. If you look at this, they're very similar to Monteja injuries of the forearm, except for the fact that the fracture of the ulna goes into the elbow joint. So, and the forearm has dislocated from the humerus. So what are the principles of treatment of a Monteja injury? Get the ulna right, and the radial head should go back where it belongs. That's the same principle here. So you want to do an extensile posterior approach most often for these. Again, you can get to the radial head for repair or replacement if it's necessary, but you want to get your ulna anatomically reduced. And if your radial head is reduced, then it's a good surrogate for proper ulnar reduction. So if we look at our 65-year-old patient with this injury, posterior approach, we put a plate on the medial side to capture the coronoid fragment, which was a very large fragment, and then a dorsal plate, which is also a non-lock plate. If you notice, you don't always need locking plates for this, but a non-lock plate on the dorsal ulna to reduce it, and she did fine. She did not get heterotopic ossification, and she healed without difficulty. But again, restoration of the ulna gives you reduction of the radial head. So now we'll go on to a little bit more of an unusual type of injury, but I've seen numerous ones of these. I just fixed one yesterday. So this is an 85-year-old patient who's highly active. He was mowing his lawn, he slipped and fell, and he sustained this elbow injury. He had trouble moving the elbow, and he came in, and let's talk about what he has going on here, because this is weird. So if we look, you look closely at his coronoid, you'll see that he has a very large coronoid fracture fragment. And in fact, it looks comminuted. So how did that happen? Well, his elbow doesn't, his elbow looks fairly well reduced here, but what we want to know is if the coronoid broke like that, then what happened on the lateral side? There are no radial head fractures here. So what about the LCL? We don't know what the condition of the LCL is at this point, especially because the elbow is nicely reduced. And that's how these often come in, with the elbow reduced. Patients will say they felt a pop, they have pain, but the elbow is well aligned. So this is a varus posterior medial fracture dislocation. They're easy to overlook. If you look at this lateral x-ray here, this is a different patient, you can see a slightly displaced coronoid fracture, but nothing else. Okay, so these are easy to miss. So you have to be aware that these are out there. If you see a coronoid fracture, you should pay attention to it. It may not need to be fixed, but you shouldn't just ignore it and say, oh, it'll be fine. So often stress views will demonstrate that the lateral collateral ligament is actually ruptured and the elbow is quite unstable. And if you're not careful, and you don't recognize these, results can be very poor. And O'Driscoll has looked at these and demonstrates subluxation of the elbow between 40 and 70 degrees of flexion in these types of injuries. So for these, you need to get to the coronoid, and I will usually split the flexor carpi ulnaris. Usually can get buttress plates and or lag screws for the coronoid fracture. And then when you're done fixing the coronoid, you can repair the LCL through a separate lateral approach if you still have instability. So this is that innocuous appearing fracture. Okay, you can see the coronoid fracture there. That's what you have to pay attention to. If we look at our 85-year-old who fell while mowing his lawn, we took him to the operating room, and a simple examination under fluoro shows his elbow is grossly unstable. Fixed his coronoid fracture with 2 buttress plates medially for 2 separate fragments. You can still see that the lateral collateral ligament is not sufficient, so the lateral joint is wide. And so we repaired it with a suture anchor repair through a separate lateral incision. He was healed and had full range of motion at 6 months, which is remarkable. These patients, when properly treated, seem to do the best out of all of the fracture dislocations of the elbow, at least in my anecdotal experience. And they generally go on to do okay if it's treated properly. So we have 4 main types of fracture dislocations that I went over. There are other weird ones that can happen, but these are the 4 main types that I see. Look for subtle signs of complex injuries. Create a surgical tactic that accomplishes the goal that's rational with regard to restoring stability. And of course, don't do anything that's going to increase instability, and that radial head, especially with a terrible triad injury, is more important than you think. Thanks very much.
Thank you, Greg. That was a great lecture as usual. In spite of being short on time, I purposefully did not, share my screen so as to save your time. but this is the introductory slide for Dr. Greg. As you can see, it's no surprise that he's had an award in excellence in teaching, the Barry Gaynor Award in 2019. Thank you very much, Greg, for that.
Thank you. Have a nice day.
Thank you very much. So next we move on to the shoulder, and that is by Dr. Nilesh Kamath, who is a senior shoulder and trauma surgeon at Sancheti and Jahangir hospitals in Pune. He specializes in complex shoulder injuries, and he's basically a arthroscopist doing both the shoulders and the knees. So he's going to talk to us about the acromioclavicular dislocations and show us the latest technique of the dog bone video with a surgical video. Over to you, Nilesh.
Right, thanks so much. Let me just share my screen. Are the slides visible?
Yes.
All right. So thanks so much. At the outset, let me start off by thanking the organizing team for the first virtual Pune operative course. It's always been an honor to be a part of this course, and it's a proud moment to represent the Sancheti Hospital for this course. My financial disclosures are I'm a paid consultant for Arthrex for their fellowship programs and for cadaveric teachings. So also let me submit to you right at the start that this is going to be a talk on the video technique and not the management of AC joint injuries. So what we'll be discussing here is management or a video stabilization of an acute AC joint injury within the first 3 weeks. Also, for all those trauma surgeons watching here, let me submit to you that this is not the only way how you can stabilize the AC joint, and the jury is still out in the open. We still don't have a definitive answer. So going on to so I wouldn't be touching the theory part of it, but if we were to revisit the biomechanical aspects, we need to understand that the primary stabilization of the AC joint is by the acromioclavicular joint and the coracoclavicular joint. Now the AC ligaments which are there, you primarily have the superior and the posterior. And now what is important to note is that the superior AC ligament contributes to nearly 56% of the resistance to posterior translation of the clavicle. Likewise, when it comes to the posterior AC ligament, that contributes to fairly around 25%. Now, why this is important is for two reasons. One is if you're doing a Mumford, it is important that when you're excising the distal 1 centimeter of the clavicle, you do not disrupt the superior AC ligament to restore whatever superior resistance is there. That's one thing. And second thing is, if you're doing a hook plate, again, you would try to get the plate from posterior rather than trying to go for superior. Although whenever you're doing an operator management, already there's a disruption of this ligament, but nevertheless, to restore it further, you would want to enter the joint from the posterior aspect. The coracoclavicular ligaments are the more important ligaments which contribute to the vertical stability. And we all know that they have the conoid and the trapezoid, and they have a triangular attachment. And when we're talking about the vertical restoration of stability, that's where the basis of arthroscopic dog bone fixation comes into picture. The Rockwood classification still holds good over the years, which is basically a spectrum of injuries, starting from the least mode of spectrum to the highest mode, where you can see that the intensity of the damage progressively increases. Literature is fairly divided, but there are certain consensual statements which come through where most of us would believe that stage 1 and stage 2, these Rockwood classification types would be conserved. Stage 4, 5, 6 would probably be requiring surgery. The debatable zone is the stage 3 injuries, which depending on patient activities, depending on the amount of overhead activities which are involved, that's when you may or may not consider an operative intervention. As I said, we are still to find the holy grail. There are various modes of AC joint fixation. And as one of my mentors had mentioned earlier, is that whenever you have multiple modes of fixation or multiple modes of stabilization for a particular problem, that means we still don't know the true answer for the problem. And I guess the search is still on, and hopefully in the years to come, we should be able to come up with a more definitive answer. So how do we go about with the AC joint stabilization? The principle here is, with a commercially available ZIG, you're going to create a tunnel across the superior surface of the clavicle into the inferior surface, which exits along the lower aspect of the coracoid. Being a cannulated drill, this can be then shuttled across with a nitinol loop, which is then retrieved through a working portal. On this loop, you then load a preloaded dog bone button with fiber tape. The idea here is that the dog bone button has to sit flush along the genu of the coracoid, and the fiber tape acts as an internal splint. Then attention is brought to the superior surface, a reduction is effected, and you stabilize the dog bone button on the superior aspect, resulting in reduction of the AC ligament, of the AC joint. So why do an arthroscopic fixation? We are in a trauma meet here, then why is it that an arthroscopist is talking about fixation of the AC joint? What Dr. Imhoff from Germany has shown is that you should strongly consider a diagnostic arthroscopy, because there is a concomitant incidence of nearly 18% of having other injuries in the shoulder, vis-a-vis a labral tear, a slap tear, a chondral injury, and so on and so forth. And this is something which we have seen in our patient group as well, that whenever there is a high velocity AC joint injury, there is a high chance that there may be a concomitant intra-articular pathology. So here is a case of a type 5 dislocation, which is more than 100% of the translation of the anterior of the acromioclavicular joint in a vertical direction. This surgery is done in a beach chair position. To give you an orientation, the horizontal structure which is seen here is the long head of biceps. The curved structure which is seen is the humeral head, and the needle is coming in through the rotator interval just off the rotator cuff. Getting a superior portal into the rotator interval, you would then use an arthroscopic radiofrequency wand to clear off the rotator interval. So on the left of the screen, you have the glenoid with the labrum. On the right of the screen, you have the humeral head. The horizontal structure which is seen below the wand is the subscapularis tendon, and the wand is working in the rotator interval. You clear off the rotator interval, and we are aware that the base of the rotator interval is formed by the coracoid process. So once you start seeing the bone, you delineate the coracoid process, and then you reorient yourself. So here you can see that the bony structure is being seen. So the tip of the coracoid process bears the conjoint tendon. On the lateral aspect, you have your acromioclavicular, your coracoacromial ligament, and on the medial side, you have the pectoralis minor. Now, once you have this orientation, you're going to get in another working portal, which is the antero-inferior portal. Now, it is important to switch your visualization from side on, because we don't use a 70-degree scope routinely, and it is very important to see the genu of the coracoid. So now when we come in from your antero-superior portal from the side, this is the new orientation that you would have. So on the left of the screen, you have the glenoid and the humeral head. As we move towards the right, you can start seeing the antero-inferior working portal with a cannula. With the probe, I'm palpating the leading edge of the subscapularis, and now you can see the genu of the coracoid. Now, it's extremely important to identify the genu and clear it of any soft tissue, because your cannulated drill is going to land right in the center of this genu of the coracoid. You can use the commercially available jig, and this jig allows you to position yourself along the width of the coracoid. And this is probably the most important and the most challenging step, because every coracoid has a different orientation, and that is the reason remaining in the center is important. Once it is drilled across, you would again want to confirm that medially and laterally you have an adequate bone bridge, because if this is skirting the margin of the coracoid, there is a high chance that either the button might flip across or it may cause a fracture of the coracoid. Once you're sure that the position is adequately central, that is when the nitinol loop is then loaded, and then that is loaded with the fiber tape and the dog bone button as what was discussed earlier. So here you can see that under direct vision, you're going to retrieve the loop across from the clavicle. And once you have retrieved the loop across from the clavicle, you let the dog bone button sit on the bone. A small surgical trick here is always use it with the grasper or the grabber and try to maneuver it in such a manner that you can under vision see that it fits and sits right across the bone rather than being on soft tissue. You can give it a tug. It's optional to do an arthroscope or a fluoroscopic visualization, but many times when you see this, you can see that the joint is already stabilized. Then attention is brought to the superior surface, a reduction is effected, the dog bone button is then brought in flush on the superior surface of the clavicle, and you have multiple half hitches which are tied. Again, a surgical trick here is that when you're doing a closure, you would want to embed these knots under the fascia. This is the fluoroscopic image. These are the portals on closure. And that's the final picture showing a perfect realignment of the acromioclavicular joint. In the post-op protocol, the patient is asked to use the arm pouch sling for around 4 weeks. Knees phase 1 stabilization exercises are started immediate post-op. Closed chain range of motion exercises are started to prevent an anterior capsular contracture. And gradually you progress to full range of motion over 12 weeks. This is a post-operative patient, and here you can see that at 8 weeks, he has a fairly decent, good range of movement and with a good cosmetically appealing scar. So what are the advantages and disadvantages? Well, firstly, it's a minimally invasive procedure with good midterm clinical results. It allows to address concomitant intra-articular pathologies. There is no need for any revision surgery for any kind of metalwork removal, which has been the trend when you use other forms of stabilization when you're doing an AC joint surgery. There is minimal metalwork or implants which remain in situ. And lastly, it's a low morbidity procedure. However, each coin has two sides to it, but this involves a steep learning curve as its main disadvantage. It's an expensive procedure, and this is important from the Indian setting where we have our patients who would not be insured in quite a few cases, and that's where you have to make a choice as to what implant you would want to use. And lastly, the long-term outcome studies are still needed because there are schools of thought where where surgeons do believe that even using a hook plate or doing a soft tissue stabilization is something which would yield adequately good clinical results. Thank you.
Thank you, Nilesh. That was a brilliant demonstration of the dog bone video. Now, just a quick question to you.
Yes.
Would you be advising surgery to all those acromioclavicular dislocations which are beyond grade 3 is one, and second, if the dog bone procedure is not affordable to the patient, what would you suggest? What is your next best option?
All right, so I'll address both the questions here. I'll just stop sharing my screen and come back to that. All right, so firstly, from indication perspective, if we are looking at a documented grade 4, 5, 6, yes, I think there is adequate evidence to say that yes, you can safely offer surgery. Grade 3 is still debatable. I would normally give them a choice of considering conservative treatment. And when we are considering conservative treatment, what is very important is that when you're doing rehabilitation, a patient with AC joint dislocation will never present as pain along the AC joint. He'll present as pain along the scapular region. So if you want a successful outcome, if you're conserving the AC joint, it's very important to pay a lot of attention on scapular kinematics. So that's something which patients can be offered. Also, in the same breath, I do counsel them that this is a procedure which can be done later on as well. But beyond 3 to 4 weeks, if the patients do present, I would usually add a soft tissue graft, a free semitendinosus autograft with the dog bone button to give some form of biological fixation rather than just relying on the implant per se for stabilization. When it comes to stage 4, 5, 6, I am biased towards surgery, and I normally offer them surgeries so that they can rehabilitate faster, because we know that if you operate them earlier, it becomes a less morbid procedure as compared to operating them late. It's the grade 3, which is still massively debatable.
Yeah.
If we are looking at a patient who is not affording a dog bone button, which does happen quite frequently.
Yes,
that's
so
when
that's why the question, because we have about 200 participants here, and everybody would not be really, keen on doing a dog bone unless, as you said, there is a steep learning curve as well.
Yes, true. So
then
that's
what's the next best?
Nilesh, one question.
Yes.
Let him answer this.
So I'll address this question and I'll come back to you. Yes, so that's when I would offer them a hook plate, and I would also try to repair the coracoclavicular ligaments either with a fiber wire or a number 5 ethibond. But sometimes it is not easy to really identify the ligaments. But yes, you could put in a loop along the coracoid and then bring it across and then get it along the clavicle, and that reduces your clavicular coracoid distance, and that allows the ligaments to heal when they're present in the acute phase.
Okay, Atul.
But the challenge here is that the hook plate, it mandates removal. So for all those who are doing a hook plate, it is very important to understand that why it went out of vogue in the first place was because it calls for a resurgery and it calls for removal of the implant.
At what time?
So usually I would offer them at around anywhere between 3 to 6 months. Around 4 to 6 months is when I would offer them a removal of the plate.
Okay. Atul, you wanted to ask something.
Yeah, Nilesh, how do you take care of acromioclavicular joint anteroposterior alignment?
So that's the reason I said we have still not found the holy grail, because here we are reducing we are restoring the vertical stability, and you're not really bringing about a horizontal stability. So when it's a chronic scenario, you can put the graft across and you're going to stabilize that. When it's an acute scenario, I do tend to put in a wire sometimes, occasionally, if I feel that there is a horizontal translation, but that wire is kept percutaneous and it comes off at a period of around 4 weeks to start mobilization before it breaks in situ.
Okay, thank you.
Thank you, Nilesh.
Thank you again. Thank you, everyone, for the invitation.
Okay, so next we move on to a slightly difficult, though rare topic, and that is the scapula. There has been a lot of literature coming up on fractures of the scapula and when and how to fix them. And I now invite a young dynamic surgeon from Pune, Dr. Rahul Damle, who heads the orthopedic surgery at Jahangir Hospital in Pune, with a special interest in complex trauma and knee reconstruction. So Rahul, please share your screen. Yes, we can see your screen, Rahul. You start speaking. Unmute yourself, Rahul.
Can you hear me?
Yeah, now we can.
Okay. Associated brachial plexus injuries, vascular injuries, splenic injuries, abdominal injuries, and major vascular injuries is another thing to be looked out for. So when you see a scapular fracture, make sure there are no associated pulmonary injuries as well. Numerous muscular attachments around the scapula, both front and back, makes the approach very challenging. I would talk about the approaches as we go along. Also, the proximity of the brachial plexus and neurovascular structures also makes the approach very challenging. The 4-7-8 triangle on the back of the scapula between the spinoglenoid notch, the suprascapular complex, and the circumflex scapular artery. One has to be very careful when approaching this area, especially going towards the lateral border of the scapula. Everyone knows about the superior shoulder suspensory complex defined by Gauss, which is formed by 6 parts, primarily the acromion, the AC joint and its ligaments, the clavicle, the CC ligaments, coracoid process, and the glenoid. Why it is important is because for an indication for a scapular fracture to be fixed, one essentially has to have a double disruption. The primary disruption is always the scapular neck, and in association to that, there's invariably a disruption of the AC joint oblique ligament and the CC ligament as well. More than 2 locations of disruptions are also possible. Sometimes triple and quadruple SSC disruptions have also been described. One has to also understand that just an ipsilateral fracture of the scapular neck and the clavicle does not produce a floating shoulder without an additional disruption of the CC and the AC ligaments. So one has to be very careful when he assesses that. So why are scapular fractures so important? The problem arises with displaced fractures of the scapula, primarily because it leads to a depressed shoulder girdle. It leads to medialization and protraction of the scapula along the chest wall, which in turn leads to rotator cuff dysfunction and scapulothoracic dyskinesia. And then later on impingement issues. And then once these fractures go into non-unions and malunions and they come to you at about 3 to 6 months down the line, it's very, very, very difficult to get them right. So it's important you catch them early. The main problem arises is when most of these patients are in the ICU when they present to you with associated chest and CNS trauma, and they are supine in the bed on an ICD or a ventilator. So it's very difficult to gauge the kind of displacement you see. Here you see a patient standing up. So it's very easy to see the displacement. But in the patients who are quite sick and in the ICU, sometimes very easy to miss those fractures or to ignore them. A few angles around the scapula. One is the GP or the glenoporal angle, which is formed by the line extending from the inferior part of the glenoid to the superior, and from the superior to the caudal part of the scapula. Normally, it is between 35 and 40 degrees. One has to understand that getting this angle right or measuring it is very difficult, sometimes in X-ray, especially in patients who are in bed on a ventilator. So it's important that you get the CT scan and measure the angles in them. It's much more easier doing that on a CT scan than in plain X-rays, because invariably the scapula goes around the chest wall and you don't get the exact true AP of the scapula. The other is the lateral border offset, or what we see the medialization, so in which there's a glenoid neck fracture and the whole scapula along with the humeral head invariably then starts going off medially as compared to the lateral border of the scapula. And the last thing to note is the extraarticular angulation, which is seen in the lateral view of the scapular Y view. Again, like I mentioned, difficult doing proper X-rays in patients who are supine and on some kind of ventilatory support. It's always a good idea to get a CT scan done, because it's very easy in the CT scans to look for all these angles. So what are the indications for surgical fixation of the scapula? As far as intraarticular fractures go, that is intraarticular fractures of the glenoid, a step up of more than 4 millimeters or involving more than 25% of the glenoid warrants internal fixation. As far as extraarticular fractures are concerned, when the glenoporal angle has dropped to 22 degrees, meaning which the neck glenoid has fallen off inferiorly, leading to a decrease in the angle, that needs to be fixed. A medialization of more than 20 mm or angular deformity of more than 30 degrees. All these are in isolation, but when seen in combination, a medialization of probably about more than 15 millimeters and an angulation of more than 30 warrants fixation. The other thing which I mentioned about are double disruptions, in which both the scapula and clavicle are displaced by more than 10 millimeters, and then that needs to be accounted and fixed as well. So there are 2 kinds of surgical approaches. One is the anterior, one is the posterior. For the intraarticular glenoid fractures, which are more in the anterior segment, a deltopectoral approach with or without a coracoid osteotomy is required, but I will be not talking about that. I'll be talking more on the posterior approach, which is done for extraarticular fractures of the scapula. There are 3 major approaches. One is the modified Judet intermuscular approach, Then is the extensile Jude submuscular approach. And then is the minimally invasive approaches, which also I will talk about. A few things about the implants. If you see many of the surgical videos available on the web, one would see these pre-contoured locking plates of the for the scapula, but unfortunately they are not available in India. So the implants which work best for us is the Recon pelvic set, because those plates can be easily molded as per the shape of the scapula, going right from the inferior spine and going along the medial border of the scapula, which I'll show in a few x-rays, and they can be contoured and molded very well. So the Recon plate from the AO pelvic set work just fantastically well. So the first is the intermuscular approach or the modified Jude approach, in which the interval between the infraspinatus and the teres minor is exploited. A reverse L-shaped incision is done along the spine of the scapula going down to the medial border. After tagging the appropriate muscles and the soft tissues, one has to try and develop the plane properly between the infraspinatus and the teres minor on the lateral border. On the medial side, one goes medial to the infraspinatus. And the trick here would be to expose both. One has to be taken great care of not injuring the circumflex scapular artery on the lateral border of the scapula, which I mentioned in the anatomy slide in the very beginning. Because if that bleeds, then you can get into trouble, because the artery then retracts anteriorly and you have no way of getting to it from the posterior approach. So this is a X-ray where you can see there's a displaced extra-articular fracture of the scapula, in which there is excessive medialization of more than about 30 to 40 millimeters, that's about 3 or 4 centimeters. So left alone, they can get into trouble in terms of range of function. So we use the intermuscular modified Jude approach to get in and fix 2 plates, one on the lateral border and one is the posterior border. One has to take great care that one is fixing the the lateral plate, that the proximal most screws don't enter into the glenoid. So director screws more medially than laterally. Some of the screws can enter into the glenoid and you can get into a lot of trouble. The position which I initially started doing the scapular fractures used to be in the prone position. But the problem with the prone position is that the scapula keeps on tending to fall off the chest wall. So you require then one assistant to constantly hold the arm and try to push the scapula up. So now I have moved on to the lateral position with the bolster in the front below the arm, which keeps the scapula back in place, as I've shown in this approach out here. This is the clinical side shown from the back. So in an extensile Jude approach, the whole infraspinatus is taken off right from the medial border of the scapula to the lateral border, as can be seen here. One has to take great care that towards the lateral border of the scapula, one can encounter the suprascapular nerve complex. So take great care while stripping the infraspinatus of the posterior border of the scapula. It's not as bad as it looks. It heals also very well, and the muscle just comes off very easily when you use a Cobb's elevator. It's just that the trapezius border has to be identified and tagged, because once one is repairing the infraspinatus and the trapezius, you can get into trouble there. So identify the muscles before cutting them and tag them. The large muscular flap is a bit of a headache to go right along the lateral border of the scapula when one is trying to do intra-articular fractures of the glenoid from the posterior aspect. So in those situations, and intramuscular approach, there's a modified Jude approach between the infraspinatus and the teres minor is probably a better approach to use. If one is extra-articular, then through the single approach without creating different planes, one can fix plates both on the medial as well as lateral side. So here you can see in this lady with a displaced fracture when the glenopural angle has gone less than 25 degrees, we have managed to lift the whole glenoid and the proximal part of the scapula up. And we have managed to put a good plate on the lateral part of the scapula with the screws being directed more medially so as to avoid an intra-articular penetration of the screws. Another X-ray, as you can see, this guy was in the ICU on a ventilator. We can watch multiple fracture ribs proximally. He was on ICD. And so we took him up for surgery because he had a displaced fracture of the clavicle as well as the scapula. Here one has to realize that with a big trauma like this and a CT scan showing these pictures, a displaced extra-articular fracture of the scapula as well as the clavicle, because the patient is supine, these fractures don't look too displaced to begin with. But once the patient starts sitting up, this shoulder droops down quite drastically and they'll end up with quite a severe compromised shoulder function. So it's important that one picks them up. Luckily for us at Jahangir Hospital, the neurosurgeon I work with quite appreciates the fact that for many of fractures, we need to get in aggressively very early in the beginning, because trying to fix this glenoid oblique clavicle fracture at about 3-4 weeks down the line is a hell of a job, especially in a head injury patient. They get very fibrotic and scarred very fast. So we have a good understanding with the neurosurgeon whereby we can go in inside the first 72 to 96 hours as well to try to get to these fractures as soon as possible. So here I can see that through a posterior approach, an extensile Jude approach, we have managed to get to the scapula, fixing the lateral border as well as the medial border. One can appreciate that using a AO recon plate from the pelvic set, we have been able to contour the plate at a virtual right angle to go from the inferior angle of the spine of the scapula right along the medial border of the scapula. And following that, we turned the patient supine and then did a clavicle plating as well. And here you can see the exercise. The fractures are fully united about 6 months down the line with an excellent shoulder function. Coming to the MIS approaches, in certain fractures, we can create twin windows, and that is what the newer norm is. One incision goes along the lateral border of the scapula, the other incision is along the medial border of the scapula. The one along the lateral border of the scapula runs from the posterolateral angle of the acromion down to the inferior border of the inferior caudal apex of the scapula, whereby the incision lies exactly over the interval between the infra and the teres minor, the plane which we exploited in the modified Jude approach, the intermuscular approach. And one can get in through there to fix the scapula lateral border, and another incision on the medial border can be used to fix the scapula without doing an extensile approach for the scapula. I think it's a good idea in the beginning of your practice to do the extensile approach, either a submuscular or intramuscular, to get the hang of things. Because for these two approaches, it may be sometimes a bit difficult in the beginning to judge the reduction of the scapula, especially in patients who present to you maybe a couple of weeks down the line. Then one may require I would prefer a submuscular approach to get to the whole of the scapula to try to get back into place. So here you can see another fracture of the scapula, and we have done a MIS approach in whereby we have exploited the interval between the infra and the teres minor from the inferior angle of the acromion to the inferior angle of the scapula. Like I mentioned, one has to watch for the circumflex scapular artery, which is just at the lateral border of the scapula, about 5 to 6 centimeters below the glenoid rim. And I cannot overemphasize putting the proximal screws directed medially so as to avoid missing the glenoid. So in short, I would like to say that fractures which are very low down, you need not fix them. The muscle attachment of the scapula in the front and the back takes very well care of them and just restores the anatomy back to normal. Some fractures along the neck of the glenoid have to be fixed depending upon how displaced they are. Whether it's a single disruption, it's a double disruption, a combined fracture along with a clavicle with a disruption of the CC and the AC ligaments. So those factors have to be accounted for. And for intra-articular fractures, which I have not talked about in this lecture, if they are displaced, one has to definitely fix them, because otherwise one will end up with a compromised shoulder function for sure. Thank you, Chair.
Thank you, Rahul, for this very precise lecture. There are two questions from you from Dr. Harjot Singh. What are the usual screw sizes in scapula, and how do you avoid bleeding issues in vessels?
So the screw sizes, the ones which are used, one has to try and catch the rim of the scapula right along the medial border and the lateral border. There's quite a dense plate of bone. If one can get the screws right, the screws are not very long. They're just probably between 12 and 14 millimeters. Obviously, it's a very thin bone. But if one can get that ridge, you get quite an adequate purchase of the plates out there. If you're in the central portion, of course, it's papery thin bone out there. So try and get the ridge of the scapula, one on the lateral, one along the medial border, and one can get decent purchase of the screws there. I've never ever used locking plates over here. It's always been those malleable synthesis silicone plates which can be contoured the way you want, and the screws can be put in whichever direction you need to.
So what's the average size like?
I think it's around 12, about between 10 and 14 millimeters. They're not very big screws, except maybe proximally near the glenoid when one is putting the screws directed medially. You can get probably slightly longer screws in because they're going along the thick part of the neck of the glenoid.
Right.
And the second question, as far as to bleeding, it is not that bad. It looks like a very bloody surgery. But what I've realized that with good hypotensive anesthesia And once gets the bleeders, even if you strip the whole infraspinatus of the posterior wall of the posterior aspect of the scapula, it doesn't bleed that much. One has to be very careful about the suprascapular artery and the spinoglenoid knots. When you lift the whole infra up, don't damage that and the nerve associated with it, obviously. But it's not such a bad BD surgery. It looks just too very devastating when you lifted the whole infraspinatus up. But it's not that bad. The approach can be done in inside 20-25 minutes. It's not that bad at all.
Okay. Thank you, Rahul. You can stop sharing the screen.
Sure. Thank you.
Can I ask one question, Chetan?
Yes, of course.
So first of all, great presentation, Dr. Damle. I just wanted to ask you, I trained with Peter Cole back in 2003, where he was really promoting scapular fracture fixation. And at that time, it was very much like the clavicle, which was, we don't operate on the scapula unless it's a floating shoulder. And there's rare indications, and the majority of time, patients do just fine. We've seen over the decades that there's been a big shift. And clearly, I suspect you and many others who treat these fractures operatively know that there is a distinct value to the, return of function. But we haven't seen a lot of comparative trials. In the clavicle, we had the pivotal trials that said operative and non-operative. Why don't we do that? It seems to me that would be now a good time to start some trials where you can definitively show it, and then many of the trainees would make it part of their training because they would realize the evidence is in favor.
I think one of the reasons, Mohit, is because it's quite a rare fracture. Rare in the sense the indications of fixing are rare, and therefore, we may need to do a multi-centric kind of a study.
Yeah, agreed. Yeah.
Thank you, Mohit. So next we move on to one of the most common fractures that we face in practice, and that is the proximal humerus. And we have none other than Dr. Sangeet Gawade. He does not need any introduction. He is the current president of the Bombay Orthopaedic Society and a senior consultant at JJ and Saifi hospitals in Mumbai. Of course, we all know that he deals with complex trauma, non-unions, deformity corrections, joint replacement, and almost everything in orthopedics. So over to you, Sangeet, to enlighten on proximal humerus.
Can you allow me to share screen?
Yes. Now you can.
So my talk is on proximal humerus fixation, and in that I will be talking on the plating aspect in an indicated fracture. We are not discussing the indications. It is elderly osteoporotic, and how would you avoid complications, and the fundamentals which are essential to understand is the reduction. Am I audible?
Yes, you are.
So the fundamentals which are essential and need to be considered is how will you reduce a 2-part, 3-part, and 4-part, because the reduction technique for all of them is different, slightly different. You cannot use the same reduction tool or a technique for reducing these 3 different varieties. Second important is how good is your achieved medial support, and what do the implant factors play or have a role in this reconstruct related to the plate and related to the number of screws what you have used, and the importance of suture augmentation. So these are the 4 fundamentals what I would be stressing on. The reduction part, as you all know, the restoration is the key, and what you need to restore is a Gothic arc, which is formed by the medial border of the proximal humerus, the shaft, the humeral head, and the lateral border of scapula. So if your reduction is not proper, you will not get a symmetric arch. And by whatever technique you achieve a reduction and fixation, if you are able to achieve that, shoulder will do well if you have achieved a good calcar reduction, if you have achieved a good reduction, and if you are able to maintain the normal Gothic arc. As I said, in these 3 varieties, the technique for reduction is different. In a 2-part, you have to lever out or give a traction to the shaft because the proximal humeral head is not disturbed. In a 3-part, it is a rotation which we have to control. And in a 4-part, we have to elevate the depressed humeral head above the tuberosities. So we start with 2-part. As you know, the head fragment in a 2-part has attached tuberosities to the humeral head. The lesser tuberosity has attached subscapularis, which is known to internally rotate, and the greater tuberosity has the teres minor, infraspinatus, and the supraspinatus, which tend to externally rotate the humeral head. Since both of them are not fractured, so the humeral head is balanced. What is displaced here is the shaft, and to reduce the shaft, you have to correct the adduction, translation, and the internal rotation of the diaphysis to get adequate reduction. In a 3-part, wherein say the lesser tuberosity is still attached to the humeral head and the greater tuberosity is fractured, so that humeral head will tend to internally rotate. So all what you have to do is you have to correct the internal rotation by giving, with some maneuver, giving an external rotation after disengaging the shaft from the humeral head. Particularly in elderly, if you don't do that, you will end up in a larger void if you try to externally rotate the shaft or try to reduce without disengaging. So that was about the 3-part. In a 4-part, the situation is totally different, where both the tuberosities are probably separated or attached to the one of them is attached to the humeral head, and it is the head which falls or which is depressed or which goes underneath the humeral head. So what you require is elevate the humeral head above the tuberosity, and ideally the greater tuberosity should be 8 millimeters to a centimeter inferior to the most superior point of the humeral head, like this. So if you are able to achieve that, you will get a good reduction. So this is the case which I am discussing. This is a 4-part humeral fracture. And if you see the CT, if you identify the bicipital groove, then you can identify the lesser tuberosity fragment, which is still attached to the humeral head. And this is the bicipital groove. And the greater tuberosity probably has 2 major fragments. Out of that, the inferior or the posterior one is displaced inferiorly. And the anterior part of the greater tuberosity is still probably attached to the humeral head. So after having identified, you know what is required for reduction. It is this fragment which has to be repositioned, and the standard workhorse is still the deltopectoral approach. After taking an incision below the coracoid like this, identify the adipose tissue over the cephalic vein, dissect the 2 bellies of the deltoid and the pec major like this. And when you're identifying that, you have to clean the adipose tissue over the cephalic vein. Very often, when you're doing that, you may rupture the cephalic vein. All we have to do is ligate it and proceed with your fixation and reduction. Next step is in between the 2 bellies of the deltoid and pec major, you have to identify the long head of biceps. After retracting the cephalic vein and the pec major on the medial side and the deltoid on the lateral side, identify for the long head of biceps. And once you identify, you know very well that on the medial side, that is the long head of biceps, on the medial side is your lesser tuberosity, on the lateral side is your greater tuberosity. Don't dissect too much superiorly, because there lies the ascending branch of the anterior humeral circumflex artery in the rotator cuff interval. So having done that, then you have to identify or pull the greater tuberosity anteriorly. Usually that fragment retracts posteriorly. So when you're using a hook, you should be careful, particularly in the elderly. Don't use the hook to pull the greater tuberosity by fixing it over the bone, because in the elderly, that tuberosity will fragment. So what you require is fix the hook on the muscular tendinous part or where the rotator cuff is attached to the tuberosity, then you can easily pull it anteriorly. Once you pull it anteriorly, then take sutures either with a fiber wire or a number 5 ethibond like this. So the bone hook is pulling it continuously so that once you abduct, you get adequate space to pass your sutures through the tuberosity. And if you complete that and hold it properly, the sutures again should not be through the bone. They should be they should be through the attached tendon on the bone. So once you do that, you can check how well that can control the whole proximal humerus. If you try to pull it with the help of a suture, you can have a good control of the proximal humerus. Usually when you use either ethibond or fiber suture, these tend to correct the varus. If you pull them medially, that means if you pull the greater tuberosity medially, the varus will be corrected. Or if you pull the lesser tuberosity with this attached fiber wire or ethibond, that will correct the retroversion. The most secure anchorage in the rotator cuff is just before it inserts on the bone. The reduction techniques which are useful is I use a small periosteum elevator, pass it through the fracture site, and it should reach the opposite cortex like this. Once it reaches that, so you can start elevating the humeral head like this and give a traction to the elbow. Once you do that and abduct a little bit, you will be able to restore the medial side. Still further, you can pass a joystick or a K wire through the humeral head like this, and that can control, or you will be able to rotate the humeral head in an appropriate direction with the help of this joystick. Once you have done that, you have passed the wire, then you can use a bone hook to give a longitudinal traction, but be careful, don't use the bone hook in the shaft where there is a comminution. At an appropriate place, you can pull it, hook it and pull it so that you can see like this, and that is a hook through the fracture side in the shaft, and the joystick or the K wire controlling the proximal humeral head. If you pull the humeral shaft with the help of a hook, you'll be able to get a good reduction and restoration of the medial calcar. Having done that, then you pass a K wire from the area which will not come in the way of your plate placement, and 1 or 2 wires are adequate to control or maintain the reduction. And having done that, just lateral to the bicipital groove, pass the plate and fix it with a cortical screw like that. You can use the screw as a reduction tool. Once you put the cortical screw, the shaft will be pulled towards the plate and you will be able to get a good reduction. Not always you will be getting that sort of reduction, or you may engage, or you may end up in a situation like this. You have passed the cortical screw, you have fixed the plate, but you have lost the reduction. The best situation is when the shaft is displaced medially. And when you try to put a cortical screw over the plate, the shaft will be pulled towards the plate, and that will help in reducing your fracture as well. So before you ensure and try to put the other screws or the calcar screw, ensure there is no varus. When you are putting this calcar screw, it should be around the calcar. It should not be in the center. If it is in the center, if it is ending up in the center, either your plate is proud or you have lost the reduction. So always the calcar screw should be in the calcar. Otherwise, it is very likely that you have a situation like this. You have passed the calcar screw, but you have lost the reduction. This is a common situation where you have lost the reduction, the calcar screw, which should be supporting the calcar, shifts towards the center. So while these are the tips which are very useful. Usually the head is retroverted. That means the shaft is displaced anteriorly. And to correct that, you have to give a traction, elevate the elbow or the arm anteriorly and push the humerus down to correct that retroversion. Usually we move the C-arm, and a lot of time is wasted in that, in getting an axial view or getting a true AP view. The best is if you externally rotate the arm, you will get a good lateral view. And if you internally rotate the arm, then you will get a view which is as good as a lateral view, which can show whether your plate is placed in the center of the humeral head and the center of the shaft. This is important because the plate is designed in a such a way that if your reduction is proper, the screws in the humeral head will be in the different sectors of the humeral head. If your reduction is not proper or the placement of the plate is not proper, they will converge in the center of the humeral head, and often you will lose the reduction. So the plate has to be in the center of shaft, center of the humeral head, and the screw should be fanning out in the different segments. Usually, only in the elderly, only the outer cortex needs to be drilled. There is no need to drill completely up to the subchondral bone, as you are using you are using a locking screw. And once you have fixed adequate screws in the proximal fragment, the attached sutures to the rotator cuff can be brought out through the plate holes which are designed. And once you achieve that, then you can check for the stability. And this is at the end after fixing adequate number of screws, that is a reconstruct, and attaching the sutures to the rotator cuff, sutures of the rotator cuff to the plate. When you do that, usually when you suture the rotator cuff to the plate, it bypasses the humeral head, and that gives a good stability to the reconstruct. The implant factors which are important is, one is the plate, which we have seen. Second is the number of screws in the humeral head. 5 screws, out of which one should be inferomedial support screw, should be good enough for the fixation. More than one calcar screw does not provide additional torsion or axial stability. So 5 screws in the humeral head are adequate for a reconstruct. And how should be your screw? They should be in a cascade fashion, wherein the superior screw should be smaller, the central screw should be longer, and the calcar or the kickstand screw should be longest. The reason is, if the head collapses or if it goes to varus, the superior screws will not migrate or penetrate the articular surface. So the key is use smaller screws superiorly, larger screws in the center, and the longest for the calcar. If you have a choice of using number of screws, usually prefer the posterior half of the humeral head. That means in a osteoporosis, in an elderly who has osteoporosis, the bone density in the posterior half of the humeral head is good. So try to take advantage by filling up more number of screws in the posterior half of the plate. In a situation where you have extensive comminution, where it is not possible to restore and maintain the calcar, you can use an intramedullary fibula, which can give an adequate support to the calcar, and you can achieve a good result at the end of 4 to 6 months like this, wherein it has healed and we have bypassed that comminuted metaphyseal area. You can also use a second plate if desired or if it is required. To conclude, the varus collapse is purely because of the malreduction, and there are various risk factors which increase the likelihood of failure. And out of that, the most important is the moment of the rotator cuff activity. If your tuberosity reduction is not adequate, the hold of the screws in osteoporosis is questionable. And if you have a varus reduction or the displacement of the head fragment at an angle which is lesser than 110 degrees, or you're not able to restore the medial calcar in the presence of comminution, if there is a lack of cortical contact, or if your kickstand screw is not in the desired position. So these are the situations which will likely to increase the failure, and this is reported up to 22%, and the screw cutout because of the varus collapse or displacement can be as high as 24%. But if you follow the tips what we have discussed, probably the complication rate can reduce significantly and your construct will improve if you follow the steps what we have discussed to end up in a good result. Thank you very much.
Thank you, Sangeet. That was a fantastic lecture as well as a demonstration of various surgical tips. A few quick questions to you from the audience. How do you fix the coronal split of humeral heads?
So if there are two large fragments, so you can temporarily hold it with K-wire or a threaded pin. Go ahead with the fixation, or if they are not coming in the way, you can put a lag screws from the lateral to the medial side if it is in a sagittal plane. Usually it is seen in the sagittal plane, not in the coronal plane. Coronal plane are the tuberosities, where again, you can put if there are two large fragments, they can be fixed in a similar fashion by antero-posterior screw in the tuberosity separately.
Okay. Second question is, any tricks to retrieve and visualize the greater tuberosity for repositioning?
One tip is always, it should be about a centimeter underneath the humeral head. So that is one key, provided you have taken a proper AP view. And that is, AP view is when you have completely externally rotated the arm, you get a proper view and a visualization of the greater tuberosity.
And one must realize that it is far too posteriorly displaced, and therefore that suture technique which you said is the right way to get it back to the front and then reposition it about a centimeter below the highest point on the humeral head, right?
So in a hefty patient, probably you will have to release the deltoid distally or superiorly, abduct the arm completely so that you have a space to go
have the access.
and reach the displaced, retracted greater tuberosity.
Right. Another question was, in an elderly four-part, is there any role of cement augmentation or a cage? Or I would rephrase this question as to when would you add the medial support? Just in comminuted fractures or any other indication where you will put a medial strut graft or an intramedullary plate, which has been also described?
When on reduction, I'm not able to get a good medial contact. The key is I should be able to get a good medial contact if there is a comminution of the medial side or it's too porotic. And fourth would be an indication where the head fragment is too small. So these are indication where I would use a fibular graft or a second plate.
Right. Another question is, in a fracture dislocation, now this is not a talk on fracture dislocations, I understand, but any quick tips on how do you get a reduction in a usually anteriorly dislocated humeral head, or if it is posteriorly dislocated humeral head in a fracture dislocation scenario?
Yeah, two things. Usually there is a buttonholing of the biceps tendon. Either you can do tenotomy or tenodesis adequately. And second is you release the rotator cuff interval. And third is partial tenotomy of the subscap, depending on whether it is anterior or the posterior dislocation. So these are the tips which can help you in reducing those anteriorly dislocated or the proximally dislocated fracture dislocations.
Right. Another tip which has been described is in a long-standing anterior dislocation, meaning a few days old, if you just can't get the reduction, then a coracoid osteotomy can be tried so that you can just reflect all the conjoint tendon and the anterior muscles away and then get the humeral head back by joysticking it into the position. Of course, you need a biceps tenotomy for it as well. Right. Thank you, Sangeet. That has been a fantastic demonstration. Thank you very much.
Thank you.
So next we move on to the hemiarthroplasty, and we have Dr. Daniel Moya. From Buenos Aires, who specializes in shoulder and scapular surgery, who is also the co-president of the 14th International Congress of Shoulder Surgery. Thank you, Dr. Moya, for being a part of this course. We really appreciate your time, given the time zones, and let us hear you on hemiarthroplasty for 4-part fractures of the humerus.
Thank you very much for the invitation. I am glad to show you. I will share my screen. Okay. Well, thank you. We have just seen that the fixation of proximal humerus fractures is perhaps the most important surgery to deal with this pathology. What about hemiarthroplasty? Well, hemiarthroplasty 20 years ago was the top of the line to deal with complex fractures, especially when it was not possible to reconstruct the proximal humerus, or when we were facing a case with a high chance of necrosis. But today, this situation has changed, and hemiarthroplasty is considered for some ones like a dying art, because when we got the chance to use reverse shoulder arthroplasties, we saw that we have more predictable results with the use of reverse shoulder arthroplasties for fractures. Anyways, there is still a role for hemiarthroplasties, and we will talk about that in this conference. We all know that proximal fractures are a very frequent problem, and some authors consider that there is a potential of a 3-fold increase by 2030. We have several treatment options. We are orthopedic surgeons, but we must not underestimate conservative treatment. There are many papers showing that conservative treatment is a very good choice, not only for undisplaced fractures, but also for people with low expectancies or elderly people. The fixation we have seen is a very important option, especially open reduction and internal fixation. And finally, when it is not possible to do so, we should choose between hemi or reverse shoulder arthroplasty. And we will see that reverse shoulder arthroplasty today is the first choice. This is a very interesting paper published by Sabesan and collaborators, and they analyze here the indications for proximal humerus fractures between 2004 and 2012. And there were not big differences in conservative treatment, but what we can see is that percutaneous procedure dropped in a very important way. The open reduction and internal fixation increases, and there was a reduction of the indications of hemiarthroplasties, and there was a dramatic growth of reverse shoulder indication. And what are the tendencies to consider in 2032? Well, we see that the fixations will keep on growing, that reverse shoulder prosthesis will keep on growing, but we can see the red line that percutaneous procedures will drop and almost disappear, but there still will be an option for hemiarthroplasties. And which are those options? Well, the profile of the patient in which we think that hemiarthroplasty is a good option are those in which it is possible to reconstruct the humeral head. There is a high risk of necrosis, especially in young patients, in which we are a little bit reluctant to implant a reverse shoulder arthroplasty. We need a functional rotator cuff. We see better results in males than in females, and we see better results under 70 years old than over 70 years old. Let's show an example. This was 55 of these patients, male, that suffered this 4-part fracture. Let's show you a 3D reconstruction to make it more clear. Here you can see the head has rotated more than 90 degrees and is facing the diaphysis of the humerus. In these cases, in which there is a high risk of necrosis, we preferred the hemiarthroplasty. And about the technique, of course, we need a good positioning, the upper limb hanging at the side of the operation table, so we can work on the diaphysis of the humerus with no problem. We use the extended deltopectoral approach, beginning in the distal third of the clavicle, passing over the coracoid, and ending in the junction of the proximal third of the humerus and the middle third of the humerus. And we go through the subcutaneous tissue that generally is completely full of blood and hemorrhage. And of course, as in all the procedures in which we approach the shoulder from anterior, we need to localize the musculocutaneous nerve and the axillary nerve, and it is easy to palpate them. We have an option that is to cut the upper third of the distal attachment of the pec major. That will give us a better view of the proximal humerus. We must consider and remember that the long head of the biceps is immediately beneath the pec major attachment, so it is important to protect it with an instrument or even with our own finger when we are cutting the pec major. The biceps is a landmark in these cases, and it is good with a scissor to accompany the biceps proximally and cut the rotator interval. And we will know that everything that is on the lateral side will be the supraspinatus and the greater tuberosity, and in the medial side, the lesser tuberosity and the subscapularis. This seems obvious, but in trauma with high energy, the tissues are infiltrated with blood, and sometimes, especially when you are beginning, it's not easy to realize where are you in the anatomy of the shoulder. Let's see again the 3D, and here we see during the surgery, as I told you, the head is facing the diaphysis. It is devoid of soft tissue attachments, and part of the head remains with the lesser tuberosity in this case. We used to measure the humeral head. Now with 3D planning, we go to surgery having much more information. And of course, we always preserve the bone marrow and the bone to use it as a bone graft later. The next step is to release the tuberosities and to release the rotator cuff so we can reattach the tuberosities in the best place. We must remember that Dr. Neer used to say that a hemiarthroplasty is a soft tissue surgery. And this was an exaggeration, but to stress that we need to find a soft tissue balance to have good results. Here we are releasing the subscapularis. After some days, there are many adherences there. We need to have the chance to have an elastic tension of the subscapularis to place the lesser tuberosity where we want. We will see it now that we can mobilize the subscapularis. And we do the same with the tuberosity and the supraspinatus and infraspinatus. The next step is to implant the stem, and one of the important points is to find the correct height. Unfortunately, the fracture will always choose to make the osteotomy too distal for our preferences. It is not the same that comparing when we are operating an osteoarthritis. So the osteotomy here is distal to the tuberosities in most of the cases, and we do not have landmarks to check where to implant correctly the prosthesis. Well, one trick is to insert the stem with the head and to perform traction of the upper limb in the axis of the arm. Then we put the head in front of the glenoid and we can measure the height. We can see it here in this 3D demonstration. It is an easy and simple procedure. We need to get tension to the deltoid. We need to make room to fix the tuberosities in its correct place. There are other landmarks that can be used. It was proposed to use the upper border of the pec major, and there is an average distance of 5.6 centimeters between this point, the point number 3, to the tip of the humeral head. And that's an option we can consider. It has also been proved that it is useful when implanting reverse shoulder arthroplasties, and authors like Torrens have even suggest that can be used to calculate the retroversion. What we used to do generally with the retroversion is to put the head of the humeral prosthesis facing the glenoid and use the forearm as a protractor. And we can measure the angle that we need, or for that specific patient, of retroversion. So that is the classical procedure. When doing that, we need to check that the tuberosities will be fixed in the correct place, and then check the stability, the mobility, the translation of the humeral head on the glenoid. And also we must consider that if positioning the lesser tuberosity on its place will not tight too much the subscapularis. So in this part of the surgery, we must consider all those points to make sure that we are constructing a good option for the proximal humerus. Then we perform holes on the shaft and pass sutures that will help us to fix the tuberosities later, and proceed with the cementation of the stem. The steps for the cementation are also important ones. They were underestimated, but it is important to use a bone plug, for instance. We go back with the bone and put the bone graft at this point. Then the final step, and very important, to fix the tuberosities to the shaft between them and to close the rotator interval. There are different options to reconstruct and to fix the tuberosities. We added one of the sutures going as a circlage around the stem, and it is very important to have sutures going from one tuberosity to the other. This is the final result, all the structure moving as one solid body. This was the result in this case. And we see that recent papers have again make attention or put attention on the hemiarthroplasty. This is a series by Valenti, 51 patients, and they conclude that the hemiarthroplasty is a valid and reliable technique. What we should point out is that we can control pain with this procedure, but the active range of motion is unpredictable. We have better results in men under 70, but even though in those patients, it is difficult to have a really clear idea of what range of motion the patient will get. It is important to use fourth generation prosthesis, so in the future we could be able to transform and to rescue this hemiarthroplasty to a reverse shoulder arthroplasty if necessary. This is another paper that published in 2017 that also 2020, that supports the use of hemiarthroplasty for very specific cases. And this is a paper by Levine from 2017 that also considered this a viable treatment option. This is an interesting case. It was a lady that was 60 years old with a 3-part fracture dislocation of the proximal humerus. And in this case, the patient couldn't afford, because of her medical insurance, modular prosthesis. So she got a prosthesis that was an old design that was done in Argentina in 1950 by Dean King, who was one of the pioneers of shoulder prosthesis, even at the same time that Neil was describing his prosthesis. As you can see, it's a monoblock prosthesis. We were able to fix the tuberosities in a good way, and this was the final result. You see a very nice range of motion, internal rotation that you will never get with reverse shoulder arthroplasty, and a nice smile of the patient. So I have the chance to train with Dr. Rockwood, who was a fan of hemiarthroplasties, and he always stressed to have a proper patient selection, especially now that we have more options in our toolbox. It is very demanding having a correct positioning of the prosthesis, the reduction and fixation of the tuberosities, followed by a wise rehabilitation program, will give us the chance to perform an arthroplasty procedure in young patients that in which perhaps it is too early to think in reverse shoulder arthroplasty. Thank you very much.
Thank you, Dr. Moya. That was an excellent, very lucid demonstration of the hemiarthroplasty, especially in an era where we see 4-part fractures being straight away offered reverse shoulder more and more often. So thank you so much one more time.
My pleasure.
It was great to have you on the course.
Thank you.
And now I think it's time to hear some evidence on proximal humerus, because we keep on hearing various things, especially after the Proffer trial. There has been, a lot of controversy about which fractures to fix, especially in the elderly. And therefore, now we have Dr. Brad Petrizo, who is also the co-chair of this course. He's been associated with the course for many years now. He is a trauma surgeon at Hamilton General Hospital. He has, in fact, just been appointed as the Associate Director of Orthopedic Surgery there in the McMaster University. He specializes in complex trauma. He has demonstrated numerous cases in this course in the previous few years. He's a great friend. So over to you, Brad, for sharing with us the recent evidence on proximal humerus.
Thank you very much. Thanks for having me and us, and for this course. I guess I can just share my screen. Sorry, the share screen stopped sharing for a second there. Is that good?
Yes, we can see you now.
Great. Yeah, thanks again. Those two talks were absolute tour de forces, especially with the techniques for the proximal humerus plating and putting in the hemi. And I just want to reiterate that the GTs are so crucial no matter what you're doing, whether you're fixing it or not. And I think that point was just brought out. But we want to, we want to talk about some evidence. McMaster and Sanchetti is all about evidence, and ortho evidence is all about evidence. And how do we use evidence to potentially guide what we do? And so, as Dr. Pradhan just mentioned, no evidence talk on the proximal humerus at this stage can go without talking about the PROFER trial. And I'm sure all of you know about it, but we're going to go through it a little bit because there's some nuances to it, and it helps us sort of guide and judge things. And for those of you who aren't on ortho evidence, this is an ACE report, and this is a report based on the PROFER trial, which was a randomized trial looking at operative versus non-operative management of proximal humerus fractures. And if you look at this risk of bias table, the green squares are good things, and the red things show that there may be some biases. And you can understand that if you're looking at evidence on operative and non-operative management, it's pretty hard to blind people. It's pretty hard to blind surgeons to what the treatment alternatives are going to be. And so for those reasons, there may be biases introduced, but we're not going to talk methodology. We're just going to talk what it shows. So they randomized 250 patients essentially with displaced proximal humerus fractures, 3 and 4 part. They had a surgical group, so they were either fixing them or replacing them with a hemi, and a non-operative group with sling immobilization. And they looked at patient functional outcome scores, so Oxford Shoulder Score and the SF-12 and the EQ-5D, and it was multi-center and randomized. So it sounds pretty intriguing. And the most important findings that they identified was that there were no real differences between surgical and non-operative management at any time point. And the subgroup analysis showed no significant differences in Oxford Shoulder scores. There were sort of equal complications in both arms. And really, there was no significant functional benefit to operatively managing these patients. And you have to ask yourself, oh, great. So that's it, done. It's like our calcaneal study years ago, just stop operating on people. Well, you and I and everybody on the call both knows, and from the last previous talks, well, there are people to operate on. So how does this particular study even guide our management? Well, if we take a little bit of a look at what the trial is composed of, it was about 80% were females over the age of 65, and about over 80% received a locking plate. So if you take a step back now, you'll realize that, well, in actual fact, this is a trial of this patient population receiving a plate or not. And only 10 patients had a hemi, and there weren't any reverses at all. And then you have to ask yourself, well, who did they operate on? Well, anybody with a fracture dislocation or something that was completely displaced were completely excluded. So now we can actually define our patient group a little bit more. So in this instance, from an external validity or a generalizability, maybe those patients who are women over the age of 65, and we can extrapolate to men with a higher physiologic age, maybe we should hold off on sort of internally fixing them with anything, and maybe we should mitigate something. Well, what we don't know is, well, should we be replacing them all? And as you last saw, with replacements and hemis and reverses going up, it's going to cost a lot of money. But in general, there is this subgroup of patient population that may benefit from just a watchful waiting and non-operative management. And you can see who that population is. Now, it was interesting to me when you look at the surgical practices. So what they did with this trial was they looked at the 11 centers, or the centers that were recruiting for the PROFER trial, and they said, well, what's their standard practice? And this is pretty much how even our standard practice goes. You'll see with the graph on the left, if you were over the age of 60 and you came in with a 3 and 4 part displaced fracture, your chances of getting a plate or a rod or a reverse or a hemi, you know, depending on where you went, that's what you're going to get. And there was no guidance. Now, of course, so if there's no guidance, now you look at cost, the graph on the right, you can see for the reverse and hemi, the costs go up multi-thousands, right? So you're looking at 4,000 or 5,000 for reverse versus minimal cost for non-operative management. So you see the practice patterns and styles were varied, and you have to ask yourself, how much do you believe this PROFER trial, and in your patient population who's older with a 3 and 4 part, what's the role of fixing it versus watchful waiting? Now we'll talk a bit more about that. How did the PROFER trial change practice? You know, we talk about randomized trials, and there's a lot of times randomized trials, and Mohit has proved that over and over again. Lots of big, powerful randomized trials don't necessarily change practice, and that's a whole nother talk and argument. But 50% of people did change practice because of this trial. And interestingly, it was mainly younger shoulder surgeons and trauma units that started to swing their practice. But the older surgeons had already started swinging away from operative management and moving to more of a non-operative thing. And I'd put myself in that category now too, where I was moving more and more away from any sort of operative management strategy. But we'll talk more a little bit. Now, ask yourself, well, do these results hold up? Okay, at a year, maybe they're no different, but what about 5 years from now? And it looks like the graphs, even 5 years out, and this was based on about 176 patients that were included in the PROFER trial. They're very similar, both for the EQ-5D and for the Oxford Shoulder Score. Still no significant difference between the two 5 years out. Now, let's look at the totality of evidence. And this is a more updated systematic review. And the systematic review systematically looks at all the evidence. But as we know, there are both observational trials and there are randomized trials, which are experimental in nature. And what this systematic review is, it took all comers looking at operative and non-operative management of the proximal humerus fracture. And they identified through their algorithm here at the bottom, 23 trials to include. So the observational data set is the one at the top here, and the randomized or experimental data set is here. Now, this is the line of no effect, meaning there's no difference. So the interesting thing between the observational data set is it's very what's called heterogeneous. Some of the results are over, but when you pool the results, there is no difference between operative and non-operative management. And you're looking at around 300 and 200 patients. The experimental data, again, trial number 1, 2, 3, all very homogeneous now almost, looking at no significant difference between operative and non-operative management. Now, what do you notice when you look at this forest plot is that the confidence limits are wide. That means our estimates of effect are pretty broad, so that the truth could be anywhere along here. And that's the sad problem when you look at small trials with small outcomes. Our effect could be anywhere from here, favoring non-operative, to over here. But when you pool the data, today the best available evidence would suggest still that there's no real benefit to operating on patients with proximal humerus fractures. And again, these are mainly older patients. So the high quality studies show a modest reduction of non-union with operative intervention, but there's a 2.5 increase in problems. So implant failure, deep infection, non-union, avascular changes. So, well, you ask yourself, well, okay, that's all well and good, but what data have we got looking at the hemi versus a shoulder, a reverse? We know that there's lots of money with reverses, and we know that have just heard that there's still a role for hemi. But when you look at this trial that looked at reverse total shoulder comparatively for hemi, again, it's a systematic review looking at all of the data and a meta-analysis. They looked at 17 trials, but only one of which was randomized. And again, this is for geriatric proximal humerus fractures. And I'm going to maintain that we all need to understand what geriatric means. And I would argue it's not just a number, there's some physiology behind it, as well as chronology. And that's going to have to be up to the individual surgeon. But if you look at the evidence, again, higher quality studies on top, lower quality studies on the bottom, the pooled totality of evidence suggests that clinical function outcomes favors the reverse for geriatric proximal humerus fractures that you choose to operate on. Now, from a cost point of view, costs are going up. From a functional point of view, for patients, you can see, interestingly, a lot of the trials have this homogeneous effect of benefit favoring the reverse over the hemi for geriatric fractures. So they suggest that their analysis includes data. There's no outcome that they evaluated in the trial in which hemi outperforms the reverse. So there was, out of all of the outcomes they looked at, hemi never did better, even in any one of them. So interesting, but you can look at this one suggesting that there's still problems with the reverse, right? We've all seen them, upwards 17, maybe 20% dislocation and 7% infection rates. You get a dislocation, you get an infection, that's a big problem. And so technical things play a big role here, potentially. But here's the interesting trial. It was published just a year and a half ago and looked at reverse arthroplasty versus non-operative management for 3 or 4 part proximal humeral fractures. Again, we're talking elderly patients. It was a prospective randomized trial, and you'll have to dig it up a little bit and have a look at the methods and see if you're comfortable and confident in what they suggest. They randomized 62 patients, so again, small, 3 or 4 part proximal humerus fractures, acute reverse versus non-op. Average age was 83, and again, 87% women, but they excluded fracture dislocations. So what do you think they identified? They identified no significant difference in any outcome. Constant, DASH, SF12, EQ5D. Again, no significant difference in problems. There was issues with the GTs healing in the reverses. There was issues with malunion, non-union, and osteonecrosis in the non-operative. But again, no difference in any outcome score. And then you start thinking, oh, what are we doing? Who are we making better? How does this evidence help me when it tells me that nothing that I'm doing is benefiting anyone? Well, we have to take a step back because we know that people benefit. But this was the first study to prospectively compare non-op management versus a reverse in the treatment of 3 and 4 part fractures. One last little thing to consider as well, you just talked about acute, but what about if we delay things? When I was training, and that was almost getting up to be 20 years ago, but not quite, but yeah, my teachers would say, hey, no, we get it in. They do better. They do way better when we do it first. Here's a systematic review and meta-analysis looking at the acute versus delayed reverse total shoulder. Again, it's reverse total shoulder in the elderly population. They found no differences between doing it acutely versus doing it delayed. And in fact, they found slightly better external rotation and some rotational differences in the delayed group as opposed to the early group, which is interesting. So what do you do? Who do you operate on? We've got multiple trials telling us don't bother operating on anybody. But the interesting thing is, those trials, I would argue, are all about the geriatric patient or the physiologically geriatric patient. So an algorithm that an algorithm is, I try and avoid surgery in the majority, except for those displaced fractures in the younger high demand patients, and you have to define that. And we heard some great technical tips and tricks from that previous talk, should you choose to fix it. And again, I'm not going to put a number on it, but the younger high demand patient, in my estimation, is up to the surgeon to define. And fracture dislocations are a clear operative indication. Now, from a surgical point of view, I would argue that most of us, at least at our center, are moving to the locked proximal humeral plate, put in the techniques that you've heard. Some people still use the proximal nail, and we don't have a lot of good evidence guiding us between them. Most have moved away from percutaneous techniques for various reasons. One is K-wires migrating into hearts. So most, I would argue, have moved to the proximal humeral locking plate in some form or another. This is the one that we use. Again, put in the technical things that you've heard. Now, the same thing, here's an elderly patient with a fracture dislocation, and the humeral head is in the axilla. Clearly here, we feel that surgery may benefit this patient. And because of all of the issues with internal fixation, the evidence would suggest we move to a reverse for function and for benefit for this patient. Now, again, for the younger patient, one last thing, if you absolutely cannot fix it, arguably, yeah, maybe that hemi is something that you should put in, knowing that a reverse is going to fail on that younger active patient. But if I'm taking a young patient with a dislocation to the OR, I'm doing my utmost to get it fixed. Older patients, for me, I'll discuss the options, but most commonly, I'm going way non-operative and doing a late stage replacement if necessary. And at least in our center, we've got 2 or 3 of our colleagues who do this specifically. And so that's the way we're moving for this, based on our take, my take, the take of the evidence. So again, an elderly patient, fracture dislocation, just like this, we decided to move to a reverse. But no one would argue in this 28-year-old with a fracture dislocation, well, this isn't something that's even going to be included in the trials, PROFOR trials specifically. So always look at who's included and who these trials are meant to be for. They are not for this patient. And this patient, I think we would all argue, needs fixation. And at our center, most commonly would get a proximal humeral locked plate using the techniques that you just heard about. And when you look at this, you'll immediately notice, there's a couple of issues with that plate. I'll leave you to figure them out. But here's a 67-year-old woman in my practice that we saw with this fracture pattern, discussed the options, elected for non-operative management. Do they all do swimmingly well? No. 6 weeks later, I don't know about this. 1 year later, I think there's a problem. There's a lot of pain, but we have a solution. And arguably it's the reverse. And again, costs, those are arguments that we have to play and to buy into. I get it. But if we're just looking about the evidence, that's what it would tell us to do. Anyway, thank you very much for that.
Thank you, Brad. Once again, it was really a great talk, clearing a lot of things. So as I understand today, if you get, I'll ask you, I know I'm repeating this. So if you get a 80-year-old fixable 3-part fracture, you would still consider conserving it?
Yeah, for sure.
Okay.
I don't know what you guys have been doing, but we've been much more. And when you have the conversation with the patients, to me, they're helping make that decision. But at least that's been our take. What about you guys?
If we talk to the patient and tell her that, look, whatever you do, either non-op or operative, your range of movement will not be more than 90 degrees. Everyone would rather opt for non-operative.
Yeah.
Anyway, thanks. Thank you so much for that. So next we move on a little farther away from the shoulder to the elbow and to talk to us about complex fractures around the distal end of the humerus. We have Dr. Jaideep Fadnis from Brighton, Sussex University Hospitals. He is a surgeon who specializes in the shoulder and elbow and upper limb. He is a member of the British Elbow and Shoulder Society and the Southeast Shoulder and Elbow Group. He has been team member of the PUNE operative trauma course. Last year, he was here to demonstrate some fantastic cases, and he'll be talking to us about the distal humerus now. So over to you, Jaideep.
Invite. I'm going to share my screen. Thanks, Chetan. Let's just hope this works. Okay. So you should be able to see my talk. Chetan, is that good?
Yeah, you're perfect.
Okay, so thank you firstly for giving me the opportunity to talk about one of my favorite fractures, so distal humeral fractures. I think we all love fixing them, and I'm going to concentrate on fixation tips and tricks. Obviously, there are some that can be treated non-operatively and some that might be appropriate for arthroplasty, just like the proximal humerus, but we're going to concentrate on fixation. So what we want to really achieve is how to get out of this talk is how to go from this multifragmentary intra-articular fracture to having a nice reduction, a nice x-ray and a good outcome. What we don't want to have, however, is this sort of problem where we get poor fixation, not listening to the principles that we're going to discuss, which results in malreduction of the articular surface, as well as non-union, plate breakage, and a general nightmare to revise. So our goals of fixation really are to get a pain-free functional range of motion and to avoid complications and reoperations. And we're going to achieve these goals ideally by getting an anatomic reduction and a stable fixation that's going to allow early range of motion and rehabilitation. And we're going to need to compress the joint and the supracondylar region to achieve this. But we also want to recognize and treat common, so the unusual problem fractures, which we'll allude to. So our biomechanical goals of fixation are really to reconstitute the proximal humerus into its structure of two columns supporting the articular block. And if we look at the articular block, the two areas that are absolutely key to reconstitute are the medial trochlear and the capitellum. And why is this? Because the distal humerus is like a hinge, and if you and the olecranon and the radial head run on these two areas, just like a train runs on tracks. So if we have to get rid of central comminution, or we can, but we must try and reconstitute these areas to avoid any varus or valgus malalignment, arthrosis, and instability. So this is an image from from Sean O'Driscoll talking about the concept of a Gothic, of a Roman arch, and how the distal humerus supports the articular block just like an arch. And if we look at the support fixing the columns, we develop this traditional type of arch. However, once we link the columns together with our screws, we're actually going a step further into modern architectural principles where the arches are linked, and this increases stability, stiffness, and for us, fixation stability. This is one of the most common questions that comes up when we start talking about distal humeral fractures in every course: parallel versus perpendicular plating. Well, actually, this argument is from an era when we didn't have locking plates. We didn't have stiff, strong locking plates, periarticular plates that are pre-contoured, or locking screws. And we were using non-locking plates, non-locking screws, and reconstruction plates. So really, this isn't so important, but what is important is it's critical to link our two columns together to give the most stable construct. Here's an example of a fracture treated where the two columns have not been linked. the columns have been fixed in some way to the humeral shaft and the surgeon has left happy, but you can see that there's a gap in the articular surface and this is going to fail early. So we can link the columns through a parallel plating construct where we plate the columns and then have parallel screws. But we can also use a perpendicular plating construct to link the columns, especially if you use these hybrid plates that still allow screws to be parallel to each other, even though the plate configuration may not be. And remember that if you have a single column fracture, you don't need two plates all the time. We can link the columns by fixing one and then linking the two together in the articular block. So this is a nice principle-based approach from the Mayo group, and you can split the principles of achieving a sound fixation into the articular and metaphyseal parts. Well, they say that each screw should pass through a plate, and that's to give us a fixed angle construct and to link the column fixation with the plate into the articular block. Each screw should engage the opposite fragment and each screw should be as long as possible, which is the same, linking into the opposite column. As many screws should be in the articular fragments, and really I aim for 4 screws, 2 from each plate into the articular block, as this is quite a narrow area. We want to get articular compression and get healing at the joint surface where possible, and the screws should interdigitate to increase stability. We want to get supracondylar compression, which is applied through the plates and with clamps. And the plates should be strong and stiff enough to resist early failure and non-union. So how do we achieve metaphyseal compression? We do this through the plates by reconstituting the articular block and then using the oval holes in the plates and clamps on both columns to compress through the plate and with the clamp. So articular compression is important, and we can get this in simple fractures, but you need to be aware that in the more complex comminuted fractures, you have to be careful about squeezing the articular block together because we'll get narrowing of the articular block. And remember that we want to maintain the width of the distal humerus to allow normal elbow tracking and prevent arthritis. But if we've got a more simple fracture, we can use a clamp to apply compression. And then we can either place a lag screw across separate to the plate, or ideally what we like to do is use a plate with a locking screw, and the screws then placed under tension maintains the compression applied with the clamp. This is what happens if we ignore the principles in a fairly simple type of humeral fracture where they haven't got adequate compression at the metaphyseal level, and they've got a non-union with plate breakage as well as a poor reduction of the articular block. And when we have this sort of situation, what we can do is try and shorten the humerus to get rid of the non-union area, or in the acute fracture where we have significant comminution in the articular block, we can actually excise this comminution and then compress the shaft into the articular block. Remember, if you do this, it's important to still compress from the shaft to the articular block, but you also need to burr out a new olecranon fossa in order to allow full extension of the olecranon. And here's an example of how that non-union was treated: refixation, compression, shortening, and maintaining the principles and achieving union and a good result. Now, it's important to remember that these principles aren't ubiquitous. Not every fracture is the same. And distal humerus fractures have a whole variety of bad actors. And for these, you need to have a varied fixation technique and a varied surgical approach to treating these fractures. One of the most common approaches is to use the paratriceps approach or Alonso Hammer's approach. And this is appropriate for extra-articular fractures and simple intra-articular fractures, where we create a window on either side of the triceps and then have access to gain an indirect reduction of the articular block. Now, the most common approach for the more common fracture, for the more complex fractures, is an olecranon osteotomy. And this gives us good visualization of the posterior 2/3 of the joint. And I'd recommend this if you're not doing a lot of distal humeral fractures, or of course, if you've got a really severe fracture. And we'd recommend a chevron type osteotomy, which gives you a bit more rotational support, but a transverse osteotomy has been reported in the literature with satisfactory results. If you do an electron osteotomy, you need to be aware that you're going to have an increased complication rate, and the majority of those complications are going to come from the fixation of the electronon. And it is going to have an adverse effect on rehabilitation because we're violating the triceps, we're creating another fracture. That's going to affect the rehab of the elbow. If you choose to do an electron osteotomy, then there's a variety of ways to fix the osteotomy. I've tried them all, but again, you need to know your poison. So if you're going to do a tension band wiring, there is going to be a 30 to 60% reoperation rate for wire removal. If you use a tension band suture, like in the bottom right, you're not going to have problems with removal, but you may have slow union rates. And with plates, there's going to be increased cost and increased reoperation for the plate removal. If you use an intramedullary technique, which I quite like, beware of the ulnar morphology. So the ulnar has a variable varus angulation and apex posterior angulation, and this changes from person to person. But the point is that if you are going to use an intramedullary device, it's important to offset the entry point laterally. So if you follow the line of the electronon, your screw is going to engage the medial cortex of the ulnar diaphysis, and when it tightens, it's going to cause gapping on the opposite side. Hence, you need to put the screw down the central axis of the ulnar rather than the electronon itself. Now, this is a pearl. I think I've learned this approach for arthroplasty. It's called the lateral paraelectronon approach, popularized for joint replacement by Graham King in Canada. And it involves an approach where we spare the triceps attachment to the electronon, but we split the triceps rather than making a lateral triceps window. And this can be done for both arthroplasty and for fracture. So in the first example, here we've got a very distal comminuted fracture in an older person. And we're performing the triceps split in the proximal part, and then going down along the anconeus on the lateral aspect of the ulnar. And what you'll see here is that by splitting the triceps, but maintaining the tendinous major attachment to the electronon, we're going to get a watertight closure at the end of the case, and we're coming down directly onto the fracture site. In this case, we can bring out the lateral ligaments and the lateral epicondyle for the arthroplasty, and we've got a good view of the distal humerus. And this is extremely useful in the below case, now in the supine position. This is a complex open fracture I did just 2 weeks ago, but you can see the humeral shaft. And by coming more centrally in the triceps than on the lateral side, we can see into the area where the comminution is and the area where we're going to reduce the lateral articular fragments to the medial side. And therefore we can get a good fixation, anatomic fixation, without violating the electronon or the triceps insertion. So you need to be aware of these certain fracture types. The complex coronal shears are a subset of distal humeral fractures I'm going to come on to shortly. The low transcondylar fractures are a real problem to gain fixation to, as these often happen in the elderly patients. And also these very unstable lateral column fractures. So here's an example of one of those, where the lateral column is fractured. It's a low capitellar fracture. And the problem with these is that they're hard to gain fixation into. And the lateral aspect of the elbow is subject to high physiological varus loads. Every time we lift our arm and rotate, we're putting a varus force, just like in an instability surgery. And if we use PA screws, then they're liable to fail by pull-out, i.e. the lateral part is going to pull out of the screws. Here's an example. a complex intra-articular open fracture, again, with what looks like very nice anatomic reduction of the articular surface. They've listened to the principles, but in the post-op period, as the patient starts moving their arms, the lateral column or the lateral capitellum spins out of the fixation, and that's because those screws have not had enough purchase. So ideally, what needed to be done was to use a lateral plate, gain fixation into the across the capitellum, and if those screws are going across, they're going to be more resistant to pull out than with PA screws, and also to increase the length of the medial screws into that fragment. And this is what was done when it was revised. You can see the long screws now heading into both fragments, as well as a small posterior plate to augment the fixation. So what about if you have separate articular fragments? You may not be able to capture all these with the screws through the plates. And traditionally we thought about using threaded wires, headless screws, PLA pins, or countersunk cortical screws. And some of these have disadvantages, like the wires are great, but they're impossible to remove if you have to do a revision procedure. Headless screws are good, but again, they're relatively large in size, and the micro AccuTracks, which are the most common in the UK, are 2.3 leading edge, but the drill size is over 3 mil, damaging the articular surface. The PLA pins don't give any compression, and the countersunk screws, we have to countersink the articular block. So this is a nice technique that I use, and we've written up. It's using locking screws from any type of locking screws. And the advantage is we can put these locking screws in through very small drill holes. So this is a 1.5 drill, and then a 2 mil screw, but we can go to 1.5 size screws. And these screws give tremendous fixation into the articular block. Because they're small, they don't get in the way of the larger fragments. And this is a technique that we very commonly use. You can see that we can bury them either into the cancellous part of the bone or through the cartilage, with almost no visible damage to the cartilage, and really strong hold in those fragments. So one thing to mention is plate working length to be aware of. Be aware that some of these plates, these are Synthes plates, they're relatively thin and they're resisting huge torque. So when you're using long bridging zones, beware that they can fail. So you need to either augment those and not use a pure bridging principle, or shorten the bone, or use stiffer plates. We get these sort of failures. We see them every so often with these thinner plates and very long bridging zones. So heterotopic ossification can be a problem in the distal humerus, and it's another very common question, both stiffness and ossification. And obviously there's some risk factors like neural axis trauma, delayed surgery, open fracture, but really I think the biggest risk is inadequate fixation and stability. And I don't routinely use prophylaxis because of the systemic side effects, poor compliance, and there can be issues with unions. So it's more important to get a stiff, rigid anatomic construct that you can move early. Now, lastly, just coming on to coronal shear fractures, this is a very awkward and different subset of fractures. And here you can see what I would call a patient with a triple arc sign. And once you see this, you know there are multiple articular fragments, and the columns are intact in these, and it's just the articular block that's fractured. This is a nice classification system that was described by Dudley, and then we modified it to add a type 4, where essentially the types talk about increasing fracture severity, where a type 4 has multiple tiny fragments created by several fracture lines in different planes, not just the coronal plane. And then the importance between the type A and type B is that the type B fractures have posterior comminution of the lateral column. And this means you cannot fix only with screws because there's nothing for the screws to hold on to. And this classification is good because it has prognostic value, severity correlates with outcome, and it forms a basis for surgical management. So here's an example of a type 1A where there's an intact cortex, and a type 1B where there's posterior comminution. So obviously this is unsuitable for screw fixation alone, and we need to do something to augment the cortex at the back, which is most commonly a plate. Most of these fractures, especially the simple types, can be approached through an extensor splitting approach, a mid-axial approach, and you can see most of the capitellum and quite a way over to the trochlear as well. However, it's the real problem of the fixation of the type 3 and 4 fractures, because we need to get a good view of these. And they're multifragmentary with medial extension, and we need to see the medial extension and the separate fragments to reduce them anatomically. We can extend the lateral approach by either reflecting the lateral ligament, performing a lateral epicondyle osteotomy, or most commonly exploiting a pre-existing epicondyle fracture to subluxate the joint open. And here, if you look carefully at the complex fractures, almost always they have an epicondyle fragment to them on the lateral aspect of the capitellum, which you can fold out of the way and almost dislocate the whole joint to get a good view for fixation. We can also use anti-glide plates to neutralize shear forces, but if you do this, you need to be aware that you can get impingement against the radial head. And again, the para-olecranon approach. So we don't do olecranon osteotomies for these fractures, which again is a common description, because if you look at this para-olecranon approach, this is a view that's far superior to an olecranon osteotomy. You get a near 360-degree view of an extremely complex fracture, and where we can get anatomic reduction, we can place our buried small locking screws and then neutralize with a plate. And we can do arthroplasty if need be through exactly the same approach. So principles of rehab: we want to do our fixation. We want our fixation to be strong enough to allow early, immediate motion. We want to avoid varus torque to protect that lateral column. And we want to use supine overhead motion to engage our muscles. And we know that this improves the range of motion achieved at the end. A nice trick is to use a tubigrip, a stocking bandage on the arm once the wounds are healed, as there's some recent evidence that shows this provides proprioceptive feedback to the elbow from the brain and improves motion. So in summary, it's important to tailor your fixation to the fracture pattern. Don't be rigid in how you approach these fractures, but do be rigid in the way you fix them. Secure the lateral column. Beware of these dangerous fracture types and consider tricep sparing approaches that will allow early motion and rehab. Thank you.
Thank you, Jaydeep. That was a really great talk on practically everything about the distal humerus fractures. Just a quick question for you. What is the role or an indication of replacement in trauma around the distal humerus?
So that's almost a separate topic, so I didn't cover it too much, but there's a definite role. And we know that in the older patients with multifragmentary fractures, there is some evidence to support primary arthroplasty. And certainly choosing those patients requires some skill, exactly like the proximal humerus. But in those fractures that are especially very low with very small fragments in osteoporotic bones, then the rehab and outcome is far better and the complication less with arthroplasty.
Okay. Another question is, in these type 4 fractures, coronal splits, which you showed, AA classification, do you ever use an anterior approach?
So the reason I don't use an anterior approach for those complex fractures is that the problem with the more complex fractures is that they don't have any posterior support to them. And through an anterior approach, you can't see the posterior columns and you can't see the backside of the articular surface. So I think an anterior approach like between the brachioradialis and biceps is quite a nice approach for a simple anterior type A fracture. But for the majority of the more complex fractures, I like to be able to see the back to fix them.
Oh. Thank you, Jaydeep. That was really a great talk.
Thanks.
So next, we move back to Brad again, who will now be talking to us about radial head fractures. Again, another difficult and a controversial topic, whether to excise, whether to fix, and whether to replace. So over to you, Brad, again.
Awesome. Thank you very much. Are we good?
Yes.
Okay, so yeah, we're talking about radial head fractures, and there are some controversies which we'll get into, but I try and like to think about it in a simple way. And, you know, I've listened to Mike McKee talk on elbows for years, and it's been drilled into us that radial head, you saw a triangle of the distal humerus, well, there's the triangle of the elbow, and that radial head plays a serious role with respect to bony stability. So if we just always keep that in the back of our minds, then we can move on from there. Now, Mason classified these in 1954, and for me, there's been, just a conceptually, it's a nice way to think about it. You know, it's either undisplaced, or it's partially articular, or it's comminuted and complete almost, right? Now, Broberg has modified this classification over the years. Hotchkiss has modified the classification, and he says, well, it's not displaced and this is 2 millimeters, or it's 30% of the head. But I tend not to think about things like that. To me, it's just, is it partial? Is it complete? And I'll tell you a couple of the other things that I think about. So type 1 being undisplaced, and we're not going to talk for the most part about type 1s because the consensus would be collar and cuff for a couple of days and get people moving. I always tell patients, just like everybody else, elbows don't like to be injured and they will get stiff. In one small little trial that we did in Edinburgh years ago when I was a fellow, you know, the last motions to come back were supination and extension. So I just tell patients that and get them moving. But it's really the displaced 2s and 3s that people talk about as being controversial. And, you know, do you fix it? Do you not fix it? If you look at the textbooks, they'd say, well, you know, all type 2s are amenable to fixation in those less than 50. And again, you'll hear from the last talk, I don't like to put numbers on things because then it always makes it difficult to make those decisions. Think physiologic, think chronologic age. And then the ones that you can't fix, do you try and fix it? The completes, do you just take it right out? Or do you replace it? And that's where the controversy lies. And we'll talk about it a little bit. Arguably, the textbooks say that if they're just too comminuted, replace it. So is there a controversy? For me, conceptually thinking about the radial head, my surgical indications are, is there block to motion and is there instability, period. Whether it be partial articular, whether it be complete articular, is there a block to motion or is there going to be instability in the elbow or in the forearm, right? Think Essex Lopresti, the acute longitudinal radio-ulnar disassociation. So block to motion, instability. That's what I think. Now, if you tend to go to surgery, fix it if you're able. David Ring tells us less than 3 big pieces, but I have a seriously low threshold for replacing it. Sometimes you'll hear phrases about, oh, just putting things together. I think there's a lot, I have a very low threshold for replacing it, even in the younger patient. If you're going to replace it, always remember the rule of thumb, do not overstuff the joint. And there are a number of different techniques, but the rule of thumb, the guiding principle is do not overstuff the joint. So look at ulnohumeral alignment, look at proximal radial ulnar alignment when the head goes in, measure the head, etc. And always take care of bony and ligamentous injuries. So you could argue an algorithm is fix it if you're able, but it's less than 3 pieces and a very low threshold for replacement. Now we'll talk a little bit more. Why is that low threshold for replacement? Well, the McMaster and the University of Western Ontario, or Western University, as it's now called in London, did this systematic review, but it was a network meta-analysis. So in a network meta-analysis, doesn't just look at treatment A and treatment B, it looks at an ability to compare treatment A with treatment B with treatment C, et cetera, with some fancy statistical techniques. And they identified, as you can see in this ACE report, that the radial head arthroplasty would be superior to open reduction internal fixation, either with metal or biodegradable implants for displaced radial head fractures. So they looked at 4 out of 20 studies were included in the network to look at radial head replacement versus ORAF. And ORAF was either with metal or bioabsorbable. And these are the risk of bias. So again, there is some biases with respect to these. You can't blind people, etc. What were the important findings? 20 studies were included, but 4 included in the network. The odds of good or excellent outcome on the Broberg-Mori scale was more likely in the radial head arthroplasty group compared to ORAF. So that's what they identified. You had a better potential functional patient-related outcomes with radial head replacement. We don't have ages here. It's all comers. And post-operative complications were less likely in the radial head arthroplasty group. Now, that's some of the best available evidence that we have suggesting that, you know what, when you look to fix these things, maybe radial head replacement is better. There is another recent systematic review that was published last year looking at clinical outcomes again after internal fixation versus arthroplasty with comminuted radial head fractures. Again, all comers, another systematic review and network meta-analysis. And they suggest indeed that radial head arthroplasty is the best treatment of choice for efficacy and safety. They also suggest, and this has got a little bit of controversy, that radial head resection is safe with respect to postoperative complications. I'm bringing that up because most of us have moved away from radial head resection, period. Why? Because of the concomitant other injuries that may be there and potential instability. The problem is when you say you can radially resect the radial head, absolutely every structure of that triangle needs to be intact for there to be some outcome. And most of us, should we not be able to fix it, at least in our center, are moving to a radial head replacement as opposed to an excision. And I'll leave that up for a bit of discussion because I'll just leave it there for now. Cochrane also suggests that there's a significant risk reduction in adverse events with replacement over internal fixation for those fractures that we can't fix. Now, this is just one of the studies that goes into all these meta-analysis and systematic reviews. And I bring it up to highlight it because the numbers are small here, right? But the number needed to treat, at least in this study, is 2. That means if I treat 2 patients with a radial head replacement, I can prevent 1 complication from an open reduction internal fixation. That's pretty significant. So again, if I think simplistically, if I absolutely can't fix this, I'm moving to a radial head replacement. Now, if you do decide to go to surgery, we are commonly using a lateral Coker approach, ECU and Ankylosing split, or a Kaplan approach. If there's associated injuries, we'll go from a posterior utilitarian incision and then raise a flap to the Coker or Kaplan approach. And so here you can see we're supine on the operating room table. This would be our incision here if we're going to use a lateral approach. And again, go through a Coker interval or a Kaplan interval. And this would be our incision here if we're going to use our, I think I can, oh, I got a laser pointer here. Our posterior approach here. And again, if you do decide to go through the posterior approach, then you can raise your flap and come through your lateral split if you need to. If there are significant concomitant injuries or we're dealing with transolecranon fracture dislocations, then I'll often put the patient in the lateral position and then use the posterior approach and bring over lateral medial as you need it. Theoretically speaking, you can work through some of the olecranon fractures, but Boyd approaches, which is in between the ulna and the radial head, are usually frowned upon because of inherent potential risks of increased HO. So again, though, here's the view that you can get through the Ankylosing ECU split. This is an older picture. There's a couple of things to point out. I'd be countersinking these a little bit more. You can see we're really dealing with 2 chunky pieces. So you want to drop these countersinks in a little bit more. I tend to pull this anterior capsule now off Once you do that, you've got full access to the front of the joint as well, should you need to go over top and fix coronoid and stuff. But that for me is actually a critical part of the, let me see if I can change the color of this pointer. Anyway, whatever. Got a critical part of the approach deep, because that really lets you get on top of that humerus and come over into the coronoid. You can see the so-called naked epicondyle here. So we know that that posterior, lateral collateral is going to be need to be repaired. And you can see how that acts as a sling. You know, conceptually, when some people think about it, you think, oh, it's a lateral, but it's not. It's a sling that pulls that radial head up and in. And so a couple of technical things to avoid the prominent hardware, because that drives people nuts. Come over the top with your capsule, as that allows you to do any concomitant work over immediately, and always repair lat legs when you're coming on the way out. If you're going to fix it, what do you need? Well, mini frag screws, small canny screws, the hand module, headless screws, plates. I really try and avoid plates. It just really drives the annular ligament crazy. There's another technique if you have just a radial head neck that you want to fix, the barrel stave technique, where you can drop 2 screws down that kind of cross down there. It's a really nice technique if you are going to fix it and you've got a chunky piece of bone that will take a screw to do that in a young active person, should you desire. Partial articular injuries can be fixed as well, but again, still I maintain, I don't always look at the x-ray or the amount of displacement. For me, it's block to motion and instability. Is there a block to motion, or is there going to be instability? And that'll drive me to fix things more often than not. Remember, if you are fixing things, Hotchkiss defines the safe zone, and that's that sort of 90-degree angle. But if you take listers and the styloid and bisect it, and then a 90 on that, that'll give you generally your safe zone, where you don't want to put metal in, because then it can disrupt the proximal radial ulnar joint. So if you're going to put stuff in, think about why it bugs people. It bugs people on the annular ligament. It bugs people if you put it in the PRUJ. So avoid those things. Now, what about replacement? When you see something that looks like this, that's going to cause a block to motion or instability. And again, I like to think simplistically. You can get really complex. This is just literally a Google research I did 2 days ago on radial head replacement. And you can see you can go as complex as you want. But for us particularly, we think of modular and metal. That's it. The 2 M's of the radial head replacement. We go modular to give us some flexibility, and we go metal. And again, the overall guiding principle is don't overstuff the joint. So go to the back table, size the head, get your implant going, and just get your neck right so that you've got your radiographic markers in terms of the ulnohumeral articulation, the proximal radial ulnar articulation. And then sometimes it's nice to have a good look at the wrist and make sure there's no significant changes from side to side. And those will help you not overstuff a joint. But again, remember the 2 M's, modular and metal. This is just a quick little video that I've got here. I got to figure out how to play it because I've got this thing. Sorry, 1 second. So this is just us. It may not be quite as clear. It's just a quick little 2-minuter, I think. This is the fracture here. We're going in. I'll put my sound down because you may hear some music. So here what we're doing is we're demonstrating that there's a block. The patient is anesthetized. The patient is asleep. And you can see that they've got good pro, but boom, soup is just not good. So we've got a block to motion. And so we've done our little lines and usually center. So we're just going to use a lateral approach. This is an isolated radial head, and you can make your incision any kind of way like that. But we like to kind of center it on the medial epicondyle and then lateral epicondyle and then come down to the radial head. We're just taking the incision down. Anybody who needs some Gravol, I apologize. And so now we're just identifying the interval between the ECU and the anconeus, coming down like that. ECU up, going up there in the extensor wad. And if you wanted to come over top of that, that would get you to Kaplan's interval. We try and take the capsular incision above where you think the lateral collateral is going to be. And here you can see us trying to take out that head. I'm sorry, it's a little bit blurry, I think. And usually I have my hand over top of the, I don't for the camera, but usually I have my hand over top of that, because if it flies out, then your sizing becomes a little bit of an issue. So always make sure you get your pieces because you need them for sizing on the back table. And so, and you'll think to yourself, well, you know what, Petrosor, that looks like a pretty chunky piece. What are you going to do here? And this is me looking at it, and we're making the decision to fix it or to replace it. But you can see that pieces, it always comes out as what you think is chunky, but it's not. It's really a flimsy piece of bone often. And as I say, I have a very low threshold for putting in a replacement. This is a modular stem. We've changed our stem, we've sized it on the back table, and we've put it in here. And we're just assessing it now. We'll get all of our views on the table, look at the DRUJ as well, make sure we've got full motion, make sure our leg is tightened up if we need to, our lateral ligament, and then close in the usual fashion. So I like to think about the radial head simplistically. Is there a block? Is there instability? And if any of those two answers are yes, think to fix it. In the young person, if you can fix it and it's less than 3 big pieces, go right ahead, use the principles that we talked about. If you can't, I would strongly argue a metal modular implant. But remember, if there is anything else going on, bony or ligamentous, you got to take care of that as well. Anyway, thank you very much.
Thank you. That was simply fantastic, Brad. One quick question. Have you tried that on trolley fixation technique?
I think you're muted, Chief.
Can you hear me? Can you hear me now? No?
Did you hear me during that talk?
Yeah.
Okay.
I don't know what's wrong here, but then I'm on unmute. Can you hear me now? No? Atul, am I audible?
Yes, sir. Sir, you are audible.
I can't hear anything.
Yes, you are audible.
Oh, I know what it
Increase
is.
the volume of the laptop.
It's me. I dropped the volume for that video.
Yeah.
Okay. So
Sorry.
my question was, there has been a paper or two about reconstructing the radial head on a trolley and then reimplanting it back. Have you tried that technique ever?
Yeah, I have. And you can do it. The problem with me is I've moved away from plates because they always drive people nuts.
Right.
So for me, if I am going to put the head on, whether I've reconstructed it on the back table or whether it's completely off, you know, like those necks, I really actually do like that barrel stave technique. I didn't show a picture of it, but it's a nice long couple of cortical screws where you can cross and catch the cortex distally, and it keeps your implants up and out of the way of the annular. And I kind of like that technique. Sorry, I should have shown a picture, but the plates, even some of those radial head plates, to me are just so bulky.
Right. Anyway, thanks, Brad, for that lovely lecture. We'll see you again for the next talks.
Okay.
Am I audible?
Yes.
Yes. So I invite Dr. Vidisha Kulkarni, who is a senior orthopedic surgeon at Swasthio Pratishthan at Meerut, and she specializes in all upper limb fractures and complex reconstructions of the upper limb. And she'll be talking to us or showing us a video about the dorsoplating of the distal radius.
Thank you, Chetan. Can I share my screen?
Yes, you can now.
problem. Okay. You see my screen?
Yes, we can see it.
First of all, I thank the organizers for organizing this first virtual operative trauma course by Sancheti and McMaster University. So this is a surgical demonstration of dorsal wrist plating. This patient, a 30-year-old male, presented with 1-month-old conservatively treated trauma to right forearm and right wrist, and he is right hand dominant person. This is his X-ray. The X-ray shows distraction at ulnar fracture, some translation at radial shaft fracture, and if you carefully see the wrist X-ray, there is intra-articular ulnar corner fracture. So a CT scan was performed of the wrist, and this is the 3D reconstruction of his right wrist. You can clearly see the dorsal ulnar corner fragment, as well as there is a small volar ulnar corner fragment. The dorsal fragment has a long metaphyseal spike also, and you can clearly see ulnar head prominence, and there is intra-articular step which looks bigger than 2 millimeter. So reconstruction of the distal radial articular surface was planned, and as the dorsal fragment is bigger, so the dorsal approach was chosen. And I'm going to show the surgical video now. So a dorsal incision in line with the third metacarpal is taken. Care is taken to create full thickness skin flaps. As the fragment was located at the medial corner, so the interval between 4th and 5th extensor compartment was chosen. First, the extensor digiti minimi tendon was identified and retracted, and then the 4th compartment was elevated, and a Hohmann retractor was placed to visualize the distal radial articular surface. 2-3 fracture lines were seen with a small sharp osteotome. The ulnar corner fragment was identified and dissected. Two fracture lines were also seen along the metaphysis, and with a small osteotome, the fragment was osteotomized and gradually mobilized like this. So this osteotome is going from dorsal to volar, and gradually, with a little tapping, the fragment was mobilized till its metaphyseal spike. And some proximal dissection was performed to accommodate for the low profile L plate. Initially, the shaft fracture was first plated by a compression plating technique. So there was a little space for only 2 screws in the proximal fragment. The fragment was carefully mobilized. You can always go for dorsal capsulotomy if you do not get reduction of the intra-articular fragment. And that is the advantage of dorsal approach. All dorsal rim fragments can be reduced well by doing dorsal wrist capsulotomy. So the fragment was osteotomized, mobilized, and pushed distally and was checked under image intensifier. This video was taken 2 days back, so there is slight repetition of image pictures. So a temporary K-wire was passed to fix this ulnar corner fragment. To hold the fragment in reduction, and for the proximal metaphyseal spike, another small wire was put. Here, as the fragment was very small, I could manage with L plate, which was slightly pre-contoured. And the first screw was put, was the cortical screw in the proximal fragment. The plate was slightly contoured distally. And once it was seated, it was checked under image intensifier that it is just proximal to the distal articular surface. And then temporary K-wires were passed once the position of the plate was confirmed. So the reduction was held with a tenaculum. And along with the plate, for the vertical fracture line, one lac screw was inserted. 2.7 lac screw was inserted just proximal to the distal radioulnar joint. An additional wire was passed through the radial styloid just to engage the volar ulnar corner. So 3 wires to hold the fragment, and then a lac screw was inserted. Temporary K-wires in the distal and proximal holes. And now the drilling for lac screw. So this screw was put to compress the dorsal ulnar corner fragment. Additional wire was also kept for the lower metaphyseal spike. So this screw compressed the fragment very well. There was some space to put 2 screws distally, one through the dorsal ulnar corner and second through the lateral fragment. And there was some fracture gap in between. Some void was there. And one cortical screw was inserted for the proximal shaft, followed by 2 distal locking screws and 1 proximal locking screw. So this is how the plate was fixed. This is post-completion image. And then after achieving good hemostasis, the retinaculum was interposed between the plate and the extensor tendons. After that, the radial styloid wire was kept like that outside the skin, and the 2 wires were bent inside, and then the closure was done. And so this was the post-op X-ray PA view of the forearm with the wrist, lateral view of the same, and the patient was mobilized the very next day. This is second post-operative day, and this is his video. Active and passive mobilization of wrist was performed, supination, pronation, as well as flexion extension. Passive physiotherapy was given. So the tip is that in dorsal plating, you have to be careful about the skin. You should elevate full thickness skin flaps. If you are planning to put 2 plates, then the plate should be applied in orthogonal fashion, at least 50 to 70 degrees apart in 2 planes, as the surface is convex, not plane. If you are applying a single plate, you may have to nibble the Lister's tubercle and slightly counter the plate. And for intra-articular reduction, you may require a dorsal capsulotomy. Take care of radial styloid fragment and dorsal ulnar lunate corner. And while closing, don't forget to put portion of retinaculum as interposition flap between the extensor tendons and the distal plate. So thank you, Chetan, for giving me this opportunity, Chetan and the organizing team.
Thank you, Vidisha. Some great tips and a good video. Just a quick question. What are your absolute indications to go dorsally for plating? Which fractures would you recommend that one should go for dorsal plating?
Yeah. Fractures with dorsal comminution, dorsal Barton fractures, especially with bigger fragments, and unstable fractures, fractures on both sides. Sometimes I do dual approach, volar as well as depending upon the fracture geometry. But for selected patients in dorsal comminuted fractures, this approach gives best intra-articular reduction. And if you use low profile plates, there is no problem of extensor tendon, friction.
Irritation.
Plate irritation, yeah.
Right.
And early active mobilization improves extensor tendon gliding as well.
Okay, so you never had problems with extensor tendons with these low plates.
But I tend to remove the plate earlier, after 6 to 7 months.
After 6 months, okay. Fine. Thank you.
Hello.
Yes, Varid. Yes, Atul.
Vidisha,
Yes.
nice presentation. Tell me one thing, when you will like to do a lower distal dorsal plating versus ligamento-taxis?
For very small fragments, juxta-articular fractures, where we cannot put a plate, I will go for external fixate along with K-wire PE. And sometimes I can use dorsal plate just to take sutures through the dorsal capsule at times.
Oh, okay.
I do use.
There is one question.
Yeah.
There is one question in question box. Will the K-wires or a lag screw irritate DRUJ?
That was put proximal to the DRUJ, and it was checked intraoperatively that it is not abutting any forearm rotation.
Then one more question. What is the indication for dual incision plating?
Sometimes the fracture is comminuted both volarly and dorsally. And volar fixation is always easy because there is a big muscle covering the plate. Problem of tender irritation is theoretically less, but somehow few dorsal fragments are not reducible through volar approach. Then you may have to take a mini incision just to reduce the fragment.
So
and
yeah,
the screw can hold those fragments.
So in a dual plating, when you do volar and dorsal both, which one do you do first?
I go volarly first. If I am unable to reduce the dorsal fragments, then I slightly then I go dorsally.
Okay.
Especially in opening vein osteotomy, it is easier to go dorsally.
Thank you very much, Vidisha.
Thank you.
You can unshare your screen so that. So from here, we dorsal plating, we move on to the volar plating, and to show us how to do it is Dr. Ravi Bharadwaj, a trauma consultant at Apollo Gleneagles, Kolkata, a good old friend of mine who is a reconstructive upper limb surgeon dealing with complex trauma of the upper limb, and he does a lot of hand as well. So over to you, Ravi, for the volar plating.
Am I audible?
Yes, you are.
Okay. So just give me a moment to share my screen. Okay. Thank you very much, Chetan and Varid. It's a pleasure. My brief today is to talk on volar plating for distal radius fractures, and rather run it as a video technique, which I'm sure this fracture all of us are doing regularly on a very commonly encountered fracture. I thought I'd put together a series of interesting cases and bring out the tips and tricks which I find useful in my practice. So to start with, I have no relevant conflict of interest or any disclosures regarding this presentation. Internal fixation in distal radius fractures increasingly popular, especially in unstable fractures. There's increasing use of volar plates, and because they allow anatomical reduction and stable fixation and early mobilization. There's a plethora of implants available on the market, each claiming to be more superior to the other. But the three mantras when any surgeon plans to fix a distal radius fracture, you should know your patient and his needs, you should know the fracture personality, and you should know your implants very well. If you know these three, half the battle is won. Let's start with a very simple thing of draping. I'll just run the short video clip. contrast it with this different way of.
Dr. Ravi, you have to give a commentary on this. The video doesn't have an audio.
Okay, sorry. So this is the second way of draping. So what I am saying is forearm has been not included. So the entire forearm has been left free with the elbow. So you can get a true lateral view. It's much easier because now you can hold both the wrist and the elbow and get it into a true lateral position, and that way you can get a proper true lateral view, which is very important when you're doing this practice. So as far as draping is concerned, try to drape above elbow. Now, ergonomics is very important. It is important to be comfortably seated, and usually you try a traction view first and a trial reduction. Even though you might have had a CT scan, a traction view is always useful on table, and you try a trial reduction. It's a good idea to mark the radial pulse and the incision that you're planning to use. And you're all familiar with the standard volar approach which we use for these fractures. Now, regards provisional fixation, normally we use K-wires to hold the fracture reduced. And very commonly, a combination of a styloid and a dorsal lunate wires is found very handy. Let's take the example of this very comminuted distal radius fracture. You can see as per the CT scan, it's a very comminuted fracture with a dorsal component. And this only sort of adds to your worry when you're trying to fix this with a volar plate. But then, if you pass 3 K-wires very judiciously, you can add on a volar plate, and also there was a dorsal component. This is something which I want to make a point. Not all dorsal fragments need to be fixed with a dorsal plate. Although it has its advantages, I think the indications are quite limited. And although I started doing a lot of dorsal plating, with the use of this technique, which I'll be alluding to in the following slides, my incidence of dorsal platings has come down considerably. So now you can see that with the K-wires in position, we are able to get a good fixation and a good restoration of the articular surface. And once the screws are in place with the volar locking plate, you can choose to remove the K-wires. The Kappanji wire is a very useful reduction tool. Consider this fracture. This was a distal radius fracture, was initially treated in a cast conservatively, proceeded to displace and have unacceptable dorsal angulation. So the plan was to treat it, with fixation. So this is a K-wire which is used as a Kappanji wire, which is advanced by hand into the fracture site, advance a bit more, and then levered, and then the fracture is reduced, and then it is driven into the opposite cortex, and that affects the reduction. And all that needs to be done is apply the plate because the fracture has been reduced, the dorsal component. Another technique to restore the sigmoid notch, it's a very common fracture pattern. You see this, there's a little bit of incongruity of the sigmoid notch. A simple pressure on the ulnar head affects reduction. So what you do is you start by putting the dorsal Kappanji wire, which I have already alluded to previously. And then once that's in place, you apply digital pressure between the ulnar head and the radial styloid. And just by squeezing it tightly, you already see there's an improvement in the congruity of the distal radius knot. You just use the pressure of the head of the ulna against the sigmoid knot. It is a very simple but effective technique to restore the congruity in this region. Another technical tip, the PQ is erased carefully, leaving a small margin to suture back over the plate once the plate fixation is done. We all know that. And while using Hohmann retractors, if you notice very carefully on the small fragment set, there are 2 different types of Hohmann retractors. There is a wide one and a narrow one. The wide one can be placed on the radial aspect, and the narrow one with a lower profile is preferred on the ulnar aspect because that causes less damage to the intraosseous membrane. And the less damage you cause to the intraosseous membrane, the better restoration of pronation and supination you get earlier with rehab in the postoperative period. Another tip is to use Langenbeck retractors to retract the soft tissue rather than Hohmann's, and this is especially useful when you're dealing with the ulnar lunate fossa fragment. It's better to use Langenbeck rather than Hohmann's, and that causes less damage to the intraosseous membrane. For stubborn radial styloid fragments which are not reduced by usual means, a release of a brachioradialis formally may be useful. So you can see this example, the radial styloid, despite traction, we were unable to get it into place. So we tried joysticking it, but doesn't working. So what we proceeded to do is use a 15 blade and erase the brachioradialis. And once that was done, the fragment was easily, manipulated into place, held provisionally with K-wire, and we proceeded to fix the fracture with a volar locking plate. So while doing it, there are two options. Some people prefer to do the distal fixation first, but some people prefer the proximal fixation. The problem with the distal fixation, especially in osteoporotic bone, you're using the plate to lever the distal fragment. If it's fixed first and then you lever the plate onto the shaft, often in osteoporotic bone, it can cause problem. So I generally prefer to go with the proximal fixation first. The plate is positioned centrally over the proximal fragment or the distal shaft of the radius. Then you put provisional K-wires to the plate K-wire holes. So in this respect, you should know your implant. Most variable angle plates or a double row of screws, the concept of the double subchondral support system. There are various designs available on the market. So the first step is to pass a cortical screw to the oval hole in the center under image intensify guidance. And once that's done, you have the option of moving the plate proximally or distally with respect to the watershed line as required to effect your fixation. Screw length can be adjusted. Usually the first cortical screw is a bit long because it needs to be bicortical. If it's longer, you can adjust it later. The distal locking screws, you can make use of the variable angle features to angle the screws to capture all the articular fragments, as is done in this case. Now screening. Sometimes the radial styloid screw appears to be intra-articular. All you have to do is, raise the forearm off 20 degrees off the table to compensate for the normal radial inclination, and you can see jolly well that the screw is intra-articular. Now with regards to the dorsal cortex, you have to avoid dorsal cortex penetration, and screws cannot be bicortical, especially locking screws. They can cause extensive tendon damage. So often, even though the plate is in place and you think your dorsal screws, your volar screws are short of the dorsal cortex, beware the problem caused by the Lister tubercle, because the screw could be well outside the second cortex, piercing it, but because of the Lister tubercle on the lateral view, still think it is well within the dorsal cortex. So screw length is very, very important. In this connection, the role of special views has been alluded to in literature, with special respect to the skyline and carpal shoot-through views. These are special views which you can use on table to make sure your screws are not penetrated the dorsal cortex. For very distal fractures, I'll offer a couple of practical tips. You might sometimes need a rim plate for very distal fractures. So this is a rim plate for that kind of fracture. And sometimes capsular stitches can be passed to the volar capsule and passed through the screw holes, distalmost K-wire holes in the plate to offer additional support and stability. You can see the sutures being passed to the distal capsule, and these were passed to the K-wire holes in the plate and the rim plate. So once the rim plate is used, you have to counsel the patient that early plate removal must be maybe necessary. And with this regard, you can refer to Sung's criteria. So rim plates usually warrant early removal, otherwise they can cause flexor tendon problems. So capsular sutures for very distal rim fractures. I'm just going to play this video. So you can see the screw holes here. So you can pass the screw holes. I can show you the holes here. So the sutures can be passed through the capsule and passed through these holes, as has been done in this case. You can see the sutures being passed through the capsule. Once you've got a couple of nice bites in the capsule, you can pass the suture through these screw holes here, which I have shown. That's a useful technique. That gives additional stability, especially in distal rim fractures. As a bailout, it is always important to plan in advance and have as much inventory with complex fractures. I always keep the small fragment set ready and also suture anchors ready. You never know when you're going to need them. So this is a case where, despite a volar locking plate fixation, there was a fragment which we had missed. The volar lunate was a fragment. And although we didn't have a special implant, we could bail out because we had a small fragment set and we had an additional screw passed distal to the plate to which we could capture the fragment. The other option for very distal fracture as a bailout is you can use a contoured K-wire under the plate. Consider this very distal fracture. So what we did was we bent a K-wire. This is a titanium K-wire which we bent in this shape, and then using this plate we passed it through drill holes in the distal fragment, and then we applied the plate on top. So although the prongs of the wire are holding the distal fragment and offering additional protection, the plate is well clear of proximal to the watershed line. So this patient went on to do very well, and he didn't require implant removal as you would normally expect it with a rim plate. For a volar lunate fossa fragment, as is alluded to here, you can see this is a special fragment here, and this involves only this. Normal, modified Henry's approach will not give access to this fragment. So with these kind of fragments, you need a separate volar ulnar approach. So it's very simple. You just make the incision a little bit more ulnar, mark the ulnar neurovascular bundle. We raise the PQ on the ulnar aspect and reflect it radially with all the flexor tendons. And you might need to extend it a little bit into the palm if required. So this requires a fragment-specific implant, and there are various companies which sort of manufacture this. Even if you don't have this, you can often use the L plate which you use on the dorsum on the opposite side, and you can buttress this fragment nicely. So in conclusion, if all you have is a hammer, everything looks like a nail. But you remember that distal radius fractures come in various configurations, and there's a plethora of different types of volar locking plates. So not all nails are the same. So you should choose your hammer wisely. Thank you very much for the opportunity, and thank you for a very patient hearing. I'm happy to take questions now.
Thank you, Ravi. That was a great talk on practically all the fractures which can be addressed with approach.
Sorry, Chetan?
It was a very good talk with very great tips about various fractures which can be done through the volar approach.
I just thought I'd show a few extended indications.
Right. You covered almost everything there, and really well. So thank you so much.
Thank you.
You covered it so well that I can't see any questions in the question box as of now. So we move on to the next talk, and that is on the scaphoid fractures by my own colleague, Dr. Warid Altaf, who is a hand and microvascular surgeon at Sancheti Hospital, Pune. So over to you, Warid.
Thank you, Dr. Pradhan, for giving this opportunity. I think moving from the trauma of the upper limb, now we are close to the wrist. And I'll be talking on scaphoid fractures, acute as well as non-unions, quickly, and giving tips and tricks of the operative technique specifically. Am I audible, sir?
Yes, you are.
Okay. So acute scaphoid fractures. I'm talking here about the percutaneous fixation of the acute scaphoid fractures, and that is the retrograde percutaneous fixation, which is commonly done in the waist and the distal pole fractures. So what we need is a hypodermic needle, which is a 17-gauge hypodermic needle, which acts as a sleeve for the guide wire. So coming quickly to the video. So this is a 24-year-old male. He has a scaphoid fracture. We can see very well here on the X-ray. It is just proximal to the waist. And this is a particular position where how this should be done. This is on a hand table in a supine position with a tourniquet on. And if you see in the lateral view, it's better to keep the wrist in hyperextension, because as all of us know that whenever there's a scaphoid fracture, there's a humpback deformity, it goes into flexion. So by doing an hyperextension, we always kind of reduce the fracture and make it aligned. So that is the AP view. How we check, we keep a guide wire or a K wire, maybe a 1.5 millimeter K wire, and check on a fluoroscopy. And once it is aligned, you make a marking. That's how we do a surface marking in this particular case. And similarly, do it in a lateral view and check it in the C-arm. In this particular screenshot, you can see that it's a bit volar, but this is centering right into the scaphoid, into the proximal pole. So once we have done with the marking, we see where the two lines intersect. And that is the point. Usually 1 centimeter proximal to that point is the point of the entry where you need to enter your guide wire. So these two lines, as shown in the video, shows the axis and the direction in which we have to drill inside. So that is a 17 number hypodermic needle. So just 2 centimeters proximal to the intersection, while assistant is giving a gentle traction to the thumb, as you can see, while hyperextending or dorsiflexing the wrist, we enter. And once we are inside, we need to feel that bone, the distal pole of the proximal. Before drilling or before entering, one must be sure that we are right on the scaphoid tuberosity, and then we start entering through the guide wire. So you need to have light drills. You need to have small hand drills for this, because using a bulky drill can create a problem that can just deviate your trajectory. So while entering, this is a one must spend some time here, because once you've entered, you need to be in a perfect position, ideally in your first attempt, because once a track is created, you may end up going into the same track again and again. So this particular case, this is the guide wire which is entered. So you check in AP and lateral view, you see the surface markings. You cross check again whether your direction is according to what you marked earlier, and then check in the C-arm again. So that is the time when you are happy and you are good to go ahead. Then this is how you measure for the, you can use a measuring device which is provided in your set, or you can use the same length guide wires like we do anywhere we are doing lag screws. So that is how we check for the length of the screws. Particularly, whatever length we get at this particular time, maybe 2 or 4 millimeter less is recommended to be taken, because to spare the articular cartilage on the either side. So then you start drilling. Once you're happy, that's the drill. So you start drilling. One important tip at this particular point of time is your axis should be exactly in line with your guide wire. If you tend to deviate from that axis, there are very high chances that the drill bit may break. The guide wire may break, because it's a very flimsy 0.8 millimeter guide wire. So this is wrong. What I'm showing right now, this should not be done. You have to make it straight like this, and then you enter. This is again wrong. So the tip here is you go straight in line, you check in your C-arm, and then go ahead and then you start drilling. So once you have drilled, another important tip I think here is that once you are entering into the proximal pole, you get that resistance, because that makes you feel that you are inside the bone. Because sometimes C-arms you can't get a clear picture, and then if you get the feel of the cortex there when you're in the proximal fragment, then you know that you are inside the proximal pole. Then that is a Herbert screw with its sleeve. There are markings in it in which will guide you when you're entering. When you're on the green mark, that means you're gone inside the bone. So that is passing of a Herbert screw. Again, you adjust your sleeve accordingly, and once you've entered, you check in the C-arm, you cross check the length. And that looks to be a proper size. So you make sure that the head is buried inside, and this particular sleeve, this has a marking on it that this guide, when you have reached this place, that means your head is buried inside the articular cartilage. So there is no violation, or there is no problem with the scaphotrapezial articulation later on. And similarly, proximally, it should be not violating the radiocarpal joint. So the screw is in place. Now it's just time to remove your guide wire. It's always advisable to remove it with a drill, because it may break if you try to remove it with a plier. And then it's just one suture you can take, and post-operatively you can immobilize. Usually for a couple of weeks is good enough, and then you're good to mobilize that particular patient. This I'm talking about acute fractures, fresh fractures. So that is the C-arm picture. It's good to take supination oblique, pronation oblique, lateral, and PA views. That is the 4 intraoperative views are very, very essential to check the correct placement of the screw. So as I told earlier, avoid this. There is high chances of breakage of guide wire if you are drilling eccentrically One important another tip is that the length of the screw usually is equal to the length of the middle phalanx of the ring finger. There have been various studies which have been done, so it can give us a rough guide to what the length of the screw is, which usually is 24 to 26 in most of the times. And this particular sleeve has markings, and when you are on the red, that means you're inside the bone, that the head is buried completely. So these are the views which are very important to be taken intraoperatively. The supination, pronation, oblique views are very important. Sometimes you may need to drill the trapezium to get the central trajectory. Sometimes it is a struggle to, enter right into the distal pole at the center. You may have to drill through the trapezium, so that can be recommended. However, if you give an hyperextension force to the thumb, this can be avoided and your trapezius goes slightly away and you can enter into the distal pole. An anti-rotation wire is recommended sometimes, because especially when you're doing non-unions, when there's a bone graft, it's advisable to put an anti-rotation wire, because your graft may pop out while passing the screw. If there's a very small proximal fragment, which also is a situation, you can add a wire from the distal pole of the scaphoid to the capitate, or from the proximal pole into the lunate, give some kind of an additional stabilization. That is recommended when there are small, tiny proximal pole fixations are to be done. So in this particular technique, there is no violation of the scaphotrapezial articulation, which most of the papers do suggest that it can be done through a scaphotrapezial articulation. Avoid this. A distraction on day one or a large diameter screw, which are to be used in capitulum around the elbow, should not be put in the scaphoid, because it may inherently distract the fracture on day one. So coming to the scaphoid non-unions in continuation with this, scaphoid non-union is a completely different thing altogether. We need to look how old it is. We need to look at the viability of the proximal fragment, and we need to plan that surgery accordingly. There is always a flexion deformity. We need to assess that. We need to see whether there's a DC deformity or not, and accordingly plan and correct that. So it's always open reduction for non-unions. Usually in waist and distal poles, a volar approach, and in proximal poles, a dorsal approach. However, even in proximal poles, one can use a volar approach as well. So this is the volar approach. Just we go over on the tendon of the FCR and slight curve over the thenar eminence. So once we are into the non-union side, so you can see very well here, this is the non-union. And to get good visualization, it is recommended to put 1 K wire into the proximal fragment. That is how it is being done here. And then similarly, you put another K wire into the distal fragment. So that joysticking of fragments is very, very important, because otherwise you won't get the complete profile of the scaphoid. You won't know how much is the volar defect and where the dorsal cortex, what is happening with the dorsal cortex, because you need to open it up. It's always crumbled in flexion. So that's how we open the non-union side, and then we actually see the defect. And in the right side, you can see when the fracture is opened. So after this, that is how the joysticking of the fragment helps. And after this, you need a high-speed burr, which is a very, very good tool whenever we are doing some small bone non-unions, or we are doing some local wrist fusions, to remove all the fibrotic tissue, to remove all the dead soft tissue which is around in the non-union side. So do it. It takes some time. We need to spend some time there till we see the bleeding ends, because we know non-unions are difficult to heal. So unless you are satisfied there, you're seeing the bleeding ends on both the sides, then you stop. And then once you're done with that, then it is the time to actually check the defect. How much is the defect? And you can use small osteotomes to see, open up the non-union site again, and then see how much is the defect, because you need to take out a bone graft in such situation. So that is the defect seen in this particular patient. And this is the bone graft. This is usually a tricortical bone graft. It should have some cortical strut in it, which gives the structural stability of the scaphoid. So that is the bone graft taken from the iliac crest, usually a triangular in shape, because we know that it's a volar wedge, anterior wedge grafting. We have to open up the volar cortex, which is deficient. and that is how the graft is. The fracture side is open. The traction has to be given to the thumb, and that is putting up that graft into the defect. And once, yeah, that is the graft in place. And you need to be sure that this graft is very well in place. You hammer it with small punch forceps hammers, and then checking of the stability of the graft. That is also very important. This is how it looks in the C arm at that particular point of time. You can see the proximal pole, you can see the graft, and you can see the distal pole. And now the alignment looks all right. It looks opened up properly. So stability of the graft is very important. This is before fixing the particular bone with a Herbert screw. This is before that. So we need to check in different range of motion whether the graft is stable or not, whether it's popping or not. There have been papers, various studies which say that a cortical graft without internal fixation is also giving good results. So a slightly oversized graft which helps both the poles in place. So this is after. Then you go ahead and, like we do a percutaneous fixation, we pass the guide wire, we pass a Herbert screw, and in this particular, as it's a non-union, we have put one anti-rotation wire in this particular case. And this is that follow-up at 4 months. So in summary, a percutaneous technique is a reliable method to fix acute scaphoid fractures. Non-unions do heal if you address the problems correctly, and optimal use of fluoroscopy helps in proper placement of the screw. Thank you very much.
Thank you, Varid. That was an excellent video and demonstration. I think it was so good that I can start doing it from tomorrow without bothering you.
Thank you, sir. I can take any questions, or we are running late, so we can give the discussion in the end. Yes.
Yes, so for the last talk of the day, I think last but not the least, I'll invite Dr. Sunil Shane, who is professor and head of Department of Orthopaedics at Nanavati and Cooper, to talk on the floating shoulder.
Right. Thank you, Chetan, and I thank you for inviting me for this wonderful course. I'm going to talk on the floating shoulder, which was a term that was coined in 1992 by Herskovisi for the ipsilateral fracture of the clavicular shaft and the scapular neck. But these injuries had been described even earlier, and way back in 1975, Gans and Neuerberger were the first one to suggest that the loss of stabilizing effect of the clavicle in case there is a fracture of the clavicle along with the scapular neck. Our understanding improved when in 1993 Gauss proposed the concept of superior shoulder suspensory complex, the SSSC, which is basically a bony and soft tissue ring that maintains a stable relationship between the axial skeleton and the upper extremity and is fundamental for the shoulder function and stability. So what is the SSSA? It is basically, as I said, a bone and soft tissue ring which connects two struts, bony struts, the superior strut being the medial portion of the clavicle, the inferior strut being the scapular body. And the SSSC is composed of the distal part of the clavicle, the AC joint, the acromion, the glenoid, the coracoid process, and the coracoacromial ligaments. And as with any ring structure, whether it's the pelvis or the C1, if there is a double disruption of this ring, which may be either because of the bony fracture or a ligamentous injury, it leads to an unstable injury. And the classic example is what we routinely call as floating shoulder, which is fracture of the clavicle along with fracture of the scapular neck. But as per this concept, if you have a fracture of the scapular neck with an associated AC joint dislocation, grade 3 or more, that also will constitute a floating shoulder. We know that most of the fractures of the scapula are high velocity blunt traumas, because otherwise scapula does not easily get fractured, being protected by the rib cage and the thick envelope of muscles around it. The mode of injury may be either a direct blow to the shoulder or a fall on the tip of the shoulder or the outstretched hand. Being high velocity injuries, majority of these fractures will have a lot of may have associated injuries which may be life or limb threatening. And his clinical assessment is always you start off with the ATLS protocol, make sure you're not missing any of these injuries. You stabilize the patient before you start assessing the injury to the shoulder per se. There will be pain, swelling in the shoulder. The weight of the arm and the pull of the muscles pull or change the contour of the shoulder to the classical deformity known as the drooping shoulder. You, of course, will have tenderness, crepitus at the fracture sites with painful restriction. As I said, don't forget, there may be even in a patient who's stable and just complaining of shoulder pain, there may be associated injuries like rib fractures, pneumohemothorax, lung contusions, head injuries, brachial plexus injuries, which need to be assessed because a lot of the outcomes, especially if you have a brachial plexus injury or multiple rib fractures on the same side, it may affect the outcome of your floating shoulder injury. The radiological assessment initially is a plain X-ray AP of the shoulder by which you can make out the injury and assess the clavicular fracture. But to assess the scapular fracture, you need the scapular views, which is a true AP of the scapula, which is perpendicular to the plane of the scapula, as well as a 90-degree to it, which is called the scapular Y view. Also, axillary lateral can be useful if the patient's pain allows him to abduct the arm to get such a view. But the main radiological investigation for these fractures remains a CT scan, especially for the scapular neck fractures, where the 3D reconstructions are very useful. And what we basically want to see on these is what type of a scapular neck fracture or glenoid neck fracture that we are dealing with. You may have an anatomic neck fracture. In this, the fracture line from the lateral border of the scapula extends superiorly and exits the superior border lateral to the coracoid process. And because of this, there is then no ligamentous attachment to this piece of the glenoid. The glenoid fossa is free moving and is very unstable fracture. Fortunately, these are very, very rare injuries. The more common is the surgical neck fracture of the scapula, where which the fracture line extends to the superior border and it is medial to the coracoid process, as a result of which the coracoid process with its attached ligaments are part of the glenoid fragment, and hence they are attached to the clavicle, which gives it some degree of stability, as you can see on the image on the left. But should there be a clavicle fracture with injury to the corococlavicular and coracoacromial ligaments, this will again make this a free floating fragment, making it very unstable. The second thing that you want to assess is the glenoid angulation, which is done by the glenopolar angulation, an angle between the glenoid face and the lateral border of the scapula. The normal range is between 30 to 45 degrees. And if this glenoid is angulated excessively with the angle becoming less than 20 degrees, it is generally associated with poor outcomes and may be an indication for surgical treatment. The third thing that we assess, which again is well done on the 3D CT, is the concept or the displacement of the glenoid medially, also known as glenoid medialization. For long, we thought it was the glenoid fragment that had displaced medially, but recent studies have compared and shown that the glenoid generally remains in place, and it is the free moving body of the scapula which is displaced laterally, and this may affect the biomechanics of the shoulder. The management is controversial in the sense there are no clear-cut guidelines on what kind of injuries and what type of management is to be done for them. And this is because well-performed prospective studies are lacking. I think Mohit had talked about this, of getting such studies done, but the numbers of floating injuries that one sees are so small that it may be difficult to have comparative randomized studies. The literature has suggested three options, which is conservative, or you may try and fixing only the clavicle fracture, or you fix both the fractures. The conservative treatment is mainly indicated, as we normally do, is for undisplaced or minimally displaced fractures, and it consists of immobilizing the shoulder in a sling till the pain is relieved and then starting early mobilization. The conservative treatment is based on the principle that most clavicle and scapular fractures do not require a formal reduction for healing. And because they especially the scapular fractures being surrounded by such thick muscles, are very vascular and tend to have early healing. Also, if there is some degree of malunion, especially the scapular fracture, this is well tolerated because the scapulothoracic and glenohumeral articulation are such mobile that any degree of malunion can be accommodated. And clavicle fractures with conservative treatment we have had series like Edwards and Ramos who have reported good results. The second option, which has been advocated by Herskovsky, Rickley et al., is you fix only the clavicle and not treat the scapular neck conservatively. This is based on the assumption that fixation of the clavicle will result in an indirect reduction and stabilization of the scapular neck fracture. Also, many a times, most surgeons will feel shy of fixing the scapula because of the complex 3D anatomy. The exposure can be difficult, and the bone fragments sometimes are so small that getting good fixation in these can be, again, a problem. Here's an example of a clavicle or a floating shoulder where only the clavicle has been fixed. But if you really assess your post-op films where you've only fixed the clavicle, where there has been a significant medial displacement of the glenoid neck, you will realize that fixing the clavicle alone does not really change the position of the glenoid. And this has been well described by Leong and Lam in the paper, where they say that the normal relationship of the scapular neck and body is not restored by fixing the clavicle alone. And they attribute this because they have different muscles on which act on both fragments. And more importantly, as I said before, now recent studies have shown that the concept of clavicle or this glenoid medialization is not true. It is not the glenoid which moves medially, but it is the free body of the scapula which moves laterally. This scapula has no connection to the clavicle, and hence regaining the length of the clavicle, and the concept of fixing the clavicle alone was once you regain the length of the clavicle, the attached ligaments, the corococlavicular and coracoacromial ligament, would pull the glenoid back laterally into its right position. But as we said, it is the body which is displaced laterally, which has no connection to the clavicle. And hence, just fixing the clavicle will not result in any change between the relationship of the scapular neck and the body. If you want to alter that, you have to go down and fix the fracture, which is what they've recommended in their paper. If you have to fix the fracture, the indications for scapular neck fixation, which Rahul has already told us in his talk earlier in the course, which if there is medialization more than 2 centimeters or the glenopolar angle is reduced to less than 20 degrees, you may do it at one stage where you place the patient in lateral position and do both your fixation in that position. But majority of us would do that in 2 stages, where first in the supine position, you would fix the clavicle because that's easier in that position, and then turn them lateral. And most of the time you'd use the modified Jude approach to approach the clavicle. Here on the picture on the left, the incision marked 1 is what is normally used, which is the classical incision. Or you may use a minimally invasive, as Rahul has already told us, which is parallel to the lateral border of the scapula. You need to detach the deltoid from the scapular spine and retract it laterally so that you expose the underlying infraspinatus and the teres minor. The classical Jude was where you lift off the infraspinatus from the subscapular infraspinatus fossa or infrascapular fossa, but this tends to be a lot more morbid, and hence the modified Jude where you use a window between the lower border of the infraspinatus and the teres minor to approach and fix your fracture. So this is the window that you can see the glenoid and the scapular neck. You reduce and fix it temporarily with K-wires before doing your final fixation with plates. If the fragment is large enough, your standard 3.5 millimeter plating system will do. But many times you'll realize once you open up that the fractures are too small. And if you use a 3.5 system, you may not get more than 1 screw in the glenoid fragment. And hence it is always a good idea to have a mini fragment set on table, so that you may have to use a 2.7 or sometimes even a 2 millimeter system. Here's an example of combined fixation done. Now, how do we decide which of these treatment options one should choose? Way back in 2006, I think Mohit, along with Lodowski, has done a meta-analysis of whatever series were available then. And they've shown that all the 3 options have given excellent and good results, which are comparable. The problem here is we do not have a standard classification for the floating shoulder injuries, and hence it makes it very difficult to know whether each of these case series are the cases that they have included are comparable or not. And hence the controversy or the dilemma of which treatment is best still continues. Complications can occur, which is malalignment, arthrosis, rotator cuff dysfunction, scapulothoracic dyskinesia, or impingement pain, and this has to be warned to the patient preoperatively. But what I want to stress is that we have certain misconceptions and myths regarding this floating shoulder injury, and at least I had that before, that if I can fix the clavicle, that will indirectly reduce my scapula. I need not go down and fix the scapula. As I've just explained before, that will not happen. If you want to restore the relationship between the glenoid neck and the body of the scapula, you'll have to go and fix the scapula. There was a fear that conservative treatment will lead to malunion, which will impair the range of motion, which is not proved in clinical practice. And the third is because the relative medial displacement of the glenoid, or the lateral displacement of the body, results in shortening of the lever arm of the rotator cuff, which may result in rotator cuff weakness. Again, this has not been borne out in clinical practice because there may be a slight increase in the lever arm of the other larger muscles of the shoulder girdle, which will compensate for whatever weakness this medialization may cause. So in summary, the treatment is not controversial. It is still not very clearly defined as to which fractures should be treated surgically or conservatively. Most of the minimally displaced fractures can be treated conservatively. Surgery is indicated mainly for significant displacement. One has to be absolutely clear that clavicle fixation will not lead to indirect reduction of the scapular neck. So if your scapular neck is not greatly displaced and your clavicle is also in a position which is clinically acceptable, you may treat these fractures conservatively. You don't have to just fix the clavicle. Malunion does not always correlate with a poor functional outcome, and there doesn't seem to be any significant loss of rotator cuff strength in clinical studies. Thank you.
Thank you, Sunil, for making this really complex topic so much simpler. I learned a lot of new things in this, especially clearing all those myths. Thank you for your patience and a great lecture. Well, gentlemen, I think we are at the end of day one of the first session today. I don't see any questions here, but then anyone wants to ask anything, on behalf of all the organizers, I really wish to thank each and every speaker. We have had a great day today and really excellent informative talks and videos. And I can't just emphasize on this. Really great knowledge in just a few hours. Mohit, do you want to say something? Mohit, are you around?
Ravi here.
Yes, Ravi.
Yeah, I would like to thank you. I think you got to a great start, and with COVID and everything, everything was down. Now it's just brought back the mojo. So
yeah,
look forward to more physical meetings in the future. So thank you. You got a kick-started on day one is excellent, and I really learned a lot, as you said. So look forward to the remaining days. So congratulations, all the best, and best wishes to the team. I think we've enjoyed ourselves. It's been a thoroughly enjoyable evening for all of us. We've all learned a lot. Thank you so much.
Thank you, Ravi. Yeah, I can just echo that. It was really an evening full of learning. Thank you, all the speakers from overseas as well as from India. And I think we'll have an equally great day tomorrow. So with this, I wish you a good time ahead.
Bye-bye.
Thank you.
Thank you. Thank you. Bye.
Thanks.
Thank you, Ashok, for all the support.
Thank you, Chetan.